anyone that has slides that hasn't sent them and wants me to put them in the main slide deck, you could email them to me now, or if you have them on your computer, we could just share the screen when it comes time, if you have slides. I have the ones for adolescent medicine and for Presley. I got those and put those into the slide deck, but anyone else, we can either share a screen or you can send them to me now.
Shannon, I don't have slides. I was just going to talk. Is that okay?
Oh yeah, that's totally fine.
Good morning.
Good morning.
Good morning.
Hey, Shannon.
Yeah, I wanted to let you know there were some people that emailed this morning that forgot to register, and so I sent them the link. So that's why there's more people than you had on the list.
I was just gonna say, like, wow, there's a lot of people on that list. We only have 7, like included me, included you, included Megan. I was like, wow. So that's okay. You don't have their registration form, do you? You don't have anything on them.
I don't, but I let people know that we will need them to register after. So if you want me to just send them a blank registration by email, I could do that. Or
no. I think what I'll do is I'll reopen the registration link, and we'll send them the link and tell them to register there. Is that okay?
Oh, that's perfect. That's even easier.
All right, let me open it up right now, and then we'll send them, and James will send them something. I'll figure this out here. Okay. Good morning.
Forward them the link.
Hi. You what?
You can just forward them the link.
All right, I'll do that. I have to reopen it. Hang on. Hi, James.
Good morning.
What do I do with glasses? Okay.
In the meantime, maybe I want to welcome everyone again. We're taking care of some housekeeping in the beginning here, since when we're doing this over video, we want to make sure we don't miss anything. Looks like just about everyone is here. And I want to thank sort of the people I usually thank, or everybody at ORT for helping us, James and Doreen, the state for financing this, all of you all for participating. I think this is actually our last meeting of these learning collaboratives, and you may have realized that you may or may not have realized, because I feel like the last 4 months, a lot of us have realizing less things, but that different group than you were before. We brought everybody all together into one group. So we can learn from each other, which I think will be nice. And we're willing to be flexible this morning. If there's more to discuss in terms of what different groups have done, we may go a little longer than 20 minutes per person, and we will be done before 12. So, I guess the next thing is, I think we're ready for James. James, do you want to do your very important housekeeping?
Yes, one moment and I'll get it started.
James, can you tell me how to send an email to everyone, or there a way I can just post this link or post instructions?
You can post it in the chat window, Doreen.
All right, thank you. God, you got it. Got it.
Good morning. My name is James Ferris, and I am functioning as the virtual AV guy for today's meeting. We ask that you keep your microphones muted until any interactive portions of the program. If you have questions during a presentation for the presenters, please enter them in the chat window at the bottom of the screen and type it there. The presenters will answer all questions at the conclusion of each talk. If you have any technical problems during today's webinar, you can send me a message via the chat function at the bottom of the screen. Before we begin, we ask that you check that the name you are logged into in Zoom is the same name you registered under for the conference. To check this, click on the Participants tab at the bottom of your screen. Find your name at the top of the Participants window. If you need to change your name, click on the More button next to your name, then select Rename. If you are attending today's conference for credit, you will not receive any credit unless your display name in Zoom matches the name you registered under for the conference. Dr. Schlesinger, take it away.
Awesome. Thank you, James. I think James could have another job in announcing, or, maybe you could get a second job in commercials. You've got a great voice. Okay, so I think everyone here knows me, but for those who don't, my name is Abby Schlesinger. I'm a child and adolescent psychiatrist, medical director of TIPS, and medical director of Smart Choices, which is the program that worked with CCP originally on the Learning Collaborative related to screening for substance use. For those of you, just to sort of go back to nuts and bolts again, you can put the chat on the right hand of your screen. You may have noticed that Doreen Barkowitz has put a registration there. If you have not registered yet and you're going to want CEUs, you definitely want to register there. We'd like you to register even if you don't want CEUs, because I believe we get some feedback that way about how things are going. As I mentioned, this is our last Learning Collaborative. We really want to thank you for hanging with us through a very unique time on multiple levels. So I believe, Shannon, do you have control of the screen now? You're going to get control of the screen next. I'm going to hand it over.
I'm going to take control and share the PowerPoint so we can just review the agenda and do some introductions. Okay, so the agenda for today, as you guys know, we have the 20-minute group presentations that all the groups put together. So the first one is the behavioral health team that's at the hospital. So that will go until about 9:20. And if your presentation runs longer than 20 minutes, there's no problem with that. We have plenty of time. So please don't feel rushed to get everything in 20 minutes. And then we have adolescent medicine, then CCP water dam, then we'll do a 15-minute break, then Safe Harbor and Presley Ridge, and then just a short 5-minute break. And then we'll wrap up just talking about sustainability and best practices related to Sbirt. So Dr. Schlesinger introduced herself, but I think everyone here knows me, but in case there's someone that is kind of just observing, my name is Shannon Myers. I'm the nurse coordinator for our Smart Choices program and have been the one on your monthly calls and at the in-person meetings for this Learning Collaborative. And I think we have Megan on as well. Megan, do you want to introduce yourself since you've been a part of this since the beginning?
Yeah, sure. Hi, I'm Megan. I'm here. I am the outpatient nurse who helps at Pine Center and then assists Shannon when she asks with some of the Smart Choices programs.
And I think next we'll just go in order of these ones on the screen here. So anyone that's from the behavioral health team at Children's Hospital, could you guys take turns introducing yourselves?
Morning, it's Gretchen Crum. I'm still working with the team at Children's. I am the Director of Clinical Care Services at Western Psychiatric. Morning, everyone.
Morning.
Good morning. It's Catherine Barbash. Can you hear me okay?
Yes.
Okay. Having some technical difficulties this morning, but I think I sorted it out. I'm the program director for the Behavioral Science Division here at Children's Hospital. And so I'm the administrative oversight for our hospital-based clinicians, as well as a clinician myself working with the plastic surgery department.
Good morning, I'm Taylor Noss. I'm one of the behavioral health clinicians in the neurology department here at the hospital and also a therapist for children's TIPS.
And I think maybe there's one more person. Maria, are you on? I think I saw her name, but maybe she's just on where she can hear us, but we can't hear her. Maria, if you have a button to unmute yourself, you can go ahead and do that, but you might not. Okay, well, I think Maria's here as well. Oh, and I forgot to mention at the beginning here, I think we had talked about it before though, that we have all of the groups that needed a final meeting around this time. We combined everyone. So that's why there's going to be some people that you maybe haven't met before, since we're bringing everyone together for this final meeting. But everyone that's in these groups has been a part of the Sbirt Learning Collaborative for the past year, some even longer than a year. So you all have very similar experience as far as doing the same sort of things, but you might be new to some of the people in this meeting. I think Maria raised her hand. I saw that go up. I don't know if there's a chat that goes along with that, but
I just sent her a message to see if I can help.
Okay, sounds good. Thank you, James. Okay, so let's go to adolescent. Oh, I'm sorry. I think I forgot Alicia as well. I think you're on the line too from the hospital. Okay, she might be having microphone difficulties.
Can you hear me?
We can now.
Oh, wonderful. Figured that out. Okay. Hi, my name's Alicia. I'm a psychologist here at Children's.
Thanks for joining us, Alicia. Okay, so I think I got everyone from the hospital. So now we'll go to adolescent medicine. If you guys could introduce yourselves to the group. Okay, I'm just going to check the participant list to see if I see any names from adolescent medicine. They might just be having a microphone issue too. Okay, I don't see their names, but they did send slides, so I think they are planning on attending. They might just be running a little bit late or something. Okay, so Dr. G, do you mind introducing yourself? I think you're the only one from Waterdam that's on, is that correct?
Yeah, I'm the only one here today. Well, Kelly's behind me, but she's got work to do.
Hi, Kelly.
So I'm Dawn Godkowitz. I'm actually one of the pediatricians with CCP Waterdam, and I've been involved in this last part of the collaborative.
Okay, and then Safe Harbor, I think we have several people from there. Do you guys mind introducing yourselves?
Sorry, hi, I'm Amy Bodo. I'm the director of outpatient therapy at Safe Harbor, and then we have 2 more people on the phone as well.
Great, thanks for calling in.
Hi, this is Lauren Orndorff. I'm a behavioral health therapist here at Safe Harbor.
And I think, is there one more person from Safe Harbor? I think, did I see maybe Emily?
Yeah, Emily's on. Maybe she's having trouble unmuting,
Okay.
Who knows?
I'm having a hard time hearing, but if you can't hear me, this is Emily Kaczynski with Safe Harbor Crisis Services.
Yeah, we can hear you, Emily. Thank you. Okay, and then I know we have Mark from Presley. Can you introduce yourself?
Yeah, can you hear me?
Yeah.
Mark Levan, I'm the clinical director for Western Pennsylvania for Presley Ridge. I don't know if I have anybody else here with me today.
I don't know why.
Yeah, I didn't see, like I thought maybe Alex might come on, but I didn't see him in the list, but maybe he'll join later.
Well, I can hold it up for all of us.
Yeah, I know you can. All right, thanks everyone. Did I miss anyone that's on the, oh, Michelle, I know I didn't have you introduce yourself yet. Could you introduce yourself, Michelle? Actually, she might be at a computer where she.
Can you hear me?
Yeah. Oh, hi.
Okay. Hi, I'm Michelle Slater. I'm new with the Smart Choices program. I'm the outpatient care coordinator. I'll be working with the adults, with teenagers, adolescents that have substance abuse issues.
Michelle. And anyone else that is on that I forgot to mention your group or just who
Shannon, I think we may have fixed Maria's microphone problem if you want to go back to her.
Oh, good. Thank you. Maria, could you introduce yourself to the group? Okay. Oh, I see you, Maria. We just can't hear you. Okay. Well, we can see that you're here, and then maybe the microphone issue might get better as we go on here. Okay. So next I wanted to just, I did show the agenda, never mind. So we can go into the first presentation then. Let me just refresh my PowerPoint real quick because I know Taylor sent me some new slides. I don't know if this will do it, but let's see. Oh, okay, I think that did work actually. Okay, so the hospital team for behavioral health, I think these are your slides. Does this look familiar, Taylor?
Yes.
Okay, so whenever you guys are ready, you can go ahead. I'm going to, let me see if I can give you control so that you can advance the slides. And then if,
and is that just with the arrows that I use it?
Yeah, just the arrows. And if it doesn't seem to be working, let me know.
Okay.
Okay, so I gave Taylor control.
Okay, yeah, I'm able to move it. Perfect. All right, so just whenever we're ready?
Whenever you're ready, yep.
Okay. So I'm gonna go ahead and get us started off. Again, my name is Taylor Noss. I'm in the neurology department with Children's Tips. And Catherine is also going to be my counterpart with kind of explaining a little bit about what we did here at the hospital to establish regular and routine substance screening with our QI project. So just a little bit of background about our clinics. In the behavioral department at Children's, we see a diverse population of children, both in typical outpatient settings, and we also have people that are embedded in the medical subspecialty clinics as well. Appointments tend to be for either initial diagnostic clarity, collaboration of care with any type of medical team, identifications for treatment, for level of care, or probably our most popular, which is brief treatment model of care, where we see them on average every other week to monthly. Patients often present with a wide range of presenting concerns and medical comorbidities. Common complaints in our clinic are low motivation, high anxiety, difficulties with sleep, and oftentimes we will see self-medicating through substance use that is likely to occur. And I think one of the biggest things for becoming a part of this QI project was just that, statistics that there was this one article that I was reading that just the vast majority are untreated because either substance screening is only done at the initial intake and then never really looked at again, or if it's just honestly done at all. So let me see here, I'm just trying to move my screen.
Is it stuck, Taylor?
Oh, here we go. And then from here, I'm going to turn it on over to Catherine.
So prior to this learning collaborative, we certainly have been screening for substance use for many years. As behavioral health clinicians, for many of us, that was already integrated into our process working with patients. However, there was a lot of variability in how that was occurring and then how that information was used. So one of the areas of variability certainly was age of patients being screened. I think that for the majority of providers, older teens were typically screened, younger teens less often, and certainly the 11 to 13-year-old group was probably the least frequently screened, probably based on several reasons: assumptions about age, discomfort, and feelings that they might offend or upset a family by asking younger children about substance use. How the information was asked was also incredibly variable, including also the extent of substances that were inquired about. There may have just been a general question, do you use drugs? Which obviously can mean a lot of different things. The information and how it was documented in our electronic medical record, which I'll talk a little bit more about, was also very variable. And then how it was utilized once collected. I think many clinicians did collect this information and then didn't know what to do with it. Next slide. So talking about where did this variability come from, training and onboarding into the department had a lot of variability. So many people would train with someone who was available to have a shadow and perhaps had a similar population. And so individual practices were passed on versus department practices. And so I think new hires would observe another clinician assessing for substance use and how they were documenting it and just continued that practice. There was lack of a universal screening tool. Just as I had mentioned, people were asking questions, but weren't necessarily using an official validated tool. And then lack of comfort with screening and brief intervention. So what do I do with this information? Is this my role? Is this relevant to my treatment? Many of our clinicians work in medical subspecialty clinics. And so they may be seeing patients for very specific targeted reasons. And sometimes we're unsure of how this substance use information fit into the goal of their evaluation and intervention. I don't know how to treat substance use. That was another area of concern or worry for clinicians. Once again, what do I do with this information when I have it? And then people being concerned about upsetting families or making them feel uncomfortable if they're inquiring about use with younger children. Other challenges that existed were also, once again, integrated medical teams. Sometimes the medical team is uncomfortable with the information and doesn't know what to do with it. I think sometimes there is a model that if we don't ask and we don't know, somehow that makes it easier. But it still certainly is an important piece of the patient's healthcare and is information that we need to know. The electronic medical record is another area of challenge. We document in the Cerner record, and we have some challenges compared to other EMRs and how to establish this screening process in an easier way compared to our other colleagues that are on Epic. And so there's variability on where this information was documented. Once again, it was based on kind of personal practices. Sometimes it was in the HPI section, sometimes it was in the social history section, sometimes it was in the safety section. So that also made it difficult to find the information consistently across providers. And then the physical location of providers. Once again, we weren't using a formal screening tool, but also until the fall of 2019, our providers were typically all in different areas of the hospital and didn't have a consistent place to store screening tools unless they had them on their own person or were able to store them in the consult rooms they typically used. So that was another area of issue, is just having a place where these tools were accessible to clinicians for use. I'm going to send it back to Taylor now.
Alrighty, thank you. So kind of looking at our goals for this quality improvement project that we had, really to ensure quality evidence-based care is being provided to all patients and not just screened as intake. As I mentioned before, just really making it part of the, kind of checking in process where we had it copied on the back of our typical PHQ-9 and GAD-7, so it was very easily accessible to all clinicians. To increase clinician confidence and comfort with screening for substance use and implementing appropriate level of intervention. As Catherine had mentioned before, just really looking at, okay, now that we have this information, what do we do with it? Normalizing substance screening and connecting that divide in care between substance and mental health treatment. I think that this is oftentimes collaboration of care between the two different providers, I think, is really a gift in this, where you are able to reach out to other providers that if you are referring out to substance treatment, being able to provide that warm handoff to the other clinician or collaborate care where you're both seeing them at the same time. Increasing the relationships, as I just mentioned, with the substance treatment providers has been really helpful as well. And also, I think just an increased knowledge of really knowing what is out there in the community and in the different counties that we serve. And then to collect data to display utilization of the effectiveness of these interventions, just to kind of show further support that we're able to effectively screen for substance screening and also effectively treat mental health concerns together. Alrighty, so really our method of implementation was that us on the quality improvement team, we would use our monthly department meetings just to kind of let all the other clinicians know that this was going to be an expected routine process, not only for good evidence-based care, but also from the data collection standpoint. So really being interactive with the people on our department, being easily accessible to make sure that we're able to support them as they're not making a major shift into this, but like trying just to make it more of a regular part of their screening. So we would typically, at the beginning, we introduced our QI project, and then at the end, or kind of throughout the middle, we would just check in with clinicians, offer additional support throughout the QI project. Reviewing the implementation of the S2BI and CRAFT substance screeners along with the intervention flow sheet to assist with knowing what to do for follow-up care. We did this a couple of ways, whether it was just our check-ins at our meetings or having the meetings that we've had at the hospital where all clinicians were kind of using the tools, whether it was through like Western Psych whenever they had come in and we learned how to do more hands-on with this type of training with like motivational interviewing aspects and things like that. Ensure that screeners were placed in a convenient location for the providers to easily complete them at the beginning of each session. So as I mentioned before, just having them simply located on the back of the PHQ-9 and the GAD-7. Getting creative with an easy means of collection of the hard copy screeners, given the barriers of the electronic medical record, as Catherine discussed. And being able to have that flow sheet easily accessible so that if any substance screening were to come up, that they were able to look at the flow sheet and then also indicate the intervention that was utilized appropriately for data collection as well. And we also had to get a little creative with this too, as everyone kind of moved home to work whenever the start of the pandemic happened. So really working with Shannon to come up with an easy way of continuing with the data collection. And, if we didn't necessarily have that hard copy to give to the patients as we were doing more telehealth. And then also plugging the results of the screener into an Excel document, because again, we didn't have the very convenient flow sheet that's accessible in Epic. So just being able to have all of that into a shared Excel document so we could continue with our data collection. So the success of our quality improvement goals, I think that we did really well with having regular use of screenings that were normalized as part of return sessions and not just at intakes, increasing the confidence of clinicians whenever working with, as Catherine had mentioned too, getting a little bit more comfortable with that preteen age, making it just kind of a standard routine 11 and older, that's who we're going to be screening. Assisted with increasing comfort of the patient being more forthcoming with some of the answers in regards to substance use. I know being a little bit more mindful of not just doing it at intake, I've seen some of the answers change as we've had more sessions because they might just be more comfortable with me and just like in the right headspace to be ready to share that type of information that might be getting in the way of treatment progress. It can also be helpful with clarifying variables that might contribute to mitigating or exacerbating symptoms. So for instance, I had mentioned a difficulty with sleep, self-medicating for anxiety. If we're able to talk about substance use and how, you know, those in terms of lifestyle factors are getting in the way of treatment progress, that can really be helpful in terms of using some motivational interviewing to really come up with a plan to cut back on some of these things so we can see if that helps with the sleep, helps with the anxiety, and so on and so forth. I feel like we have had a better connection to community substance use treatment and resource programs. I had a very helpful patient that worked with the Smart Choices Collaborative with Shannon, which has been wonderful, super easy to work with, but not only that, if that wasn't going to be a right fit for the Smart Choices program, also knowing that I could collaborate with Shannon to find the correct level of care, whether it was IOP or something else a little bit more in traditional outpatient setting. An improvement and increased use of motivational interviewing strategies that are not only helpful with this type of population, but also I think with addressing any ambivalence to treatment, and I think also effective communication within the family unit. So looking at areas of development for future use, I think continuing the development of comfort with substance screening tools with clinicians during the onboarding process is something that we're looking at. So making sure that whenever we are coming up with the shadowing of a new orientee, just making sure that this is a type of process that we have to make sure that we're able to offer that. I know Alicia Miller, who introduced herself, she's participating on this call now just to kind of get more of an idea of the substance screening part of it and things like that. So just really making that part of the onboarding process. Having all clinicians complete Cognito training, which is a lovely tool to assist with some of this if you feel like you need a little bit of practice before bringing it to your clinic. Involving smart choices routinely in agenda of department meetings was another idea that we had to really keep the dialogue going regarding it. And then collaborating with informatics team regarding screeners being added to progress note of the EMR for continuity of care. Sometimes I think this can be an uphill battle, but I think definitely keeping that also in the dialogue so we can make sure that it could be a little easier, like I said, with Epic being like super simple of just plugging it into a flow sheet, ideally having something like that to add to our EMR. All right, and I think that was all of our slides. Any questions?
Thank you so much, Taylor and Catherine. I think that was a really thorough overview. I'm just going to try to maybe get out of this screen real quick. I just want to get back to like the regular screen so I can see people while we talk. Yeah, I think that you guys, since, you know, I've been involved since the beginning, I got to see all of the challenges you were up against at the beginning and still, you know, continue to face like the medical record issue. Like you said, Taylor, I think that's going to continue to be an uphill battle, but I'm confident that eventually it'll happen. But yeah, there's so many things that you guys as a team had to work through, and the fact that you were able to get screening implemented there and then collect the screening tools, incorporate smart choices and the screening tools into so many of your meetings. I think there was like 2 or 3 meetings that I was involved with where we talked about Sbirt, and I'm sure you talked about it at other meetings too that I wasn't a part of. So I think it really speaks to your commitment to continuing to, include this in the process and get people at the hospital more comfortable with Sbirt, and like you said, with the new staff too, getting people that are coming on familiar with it so that when they are up and running, they can have Sbirt be a part of what they do in their day-to-day routine with patients. Sorry, I'm just struggling to get this back out of the.
What are you trying to do, Shannon?
I just wanted to get back to like the regular Zoom screen so I could see the people I'm talking to instead of see like the slide. It's not that big of a deal, but.
Would you like me to stop your screen sharing?
Yeah, do you mind? Okay, yeah, that just makes it a little better when I can see you. Yeah, so I think that it really just speaks to the commitment of your team down there. And I think you also had a lot of changes as far as the people in the department too. I think there was quite a few people that were involved at the beginning but left to go work at other places. So that really made the team smaller, but you and Catherine, Maria and Gretchen just really continued to push forward with it. Abby, do you have anything to add to it? Because I know that you are also very familiar with how things were before the Learning Collaborative started. And
well, I guess I have a cell first. Cognito, I think we only have Cognito for another couple months. So probably you want to tell people there's an endpoint that sometimes that helps people to get to actually do it that are putting it off. So I give them a deadline because that will be ending soon. We expanded it a couple months so that we can meet people's needs. But I guess I have some questions for you all. We've definitely seen throughout this sort of a wide variety from people saying like, I don't need to do this, to like, I already know how to do this. And I'm wondering where your group fell and how you managed those sort of responses or suggestions you have for others.
Yeah, I think, go ahead, Taylor.
I was just going to say we did the survey before to kind of gauge people's comfort levels. So we had sent out a survey, I forgot to mention that, just to kind of, before we started all of this, really get an idea of how they were feeling so we could know what areas that we needed to further support and supplement. But I think that for the most part, people felt comfortable. I think the biggest thing was, like Catherine was saying, with the age range, just making it not for, what we're thinking of like 15 and older, like really getting below. I think that was like the biggest part.
Mm-hmm, mm-hmm. Catherine, do you have anything you want to?
I agree. I think it was very age specific. Like I said, for the older teens, I think people felt that was a standard of care and they felt comfortable doing it. But for the younger teens, people were less comfortable. And part of that really, I think, was they felt uncomfortable that they were going to frustrate a family or offend a family and it's useful to have the tool, and it even says like ages 11 and up, and you just say, oh, we give this to everyone 11 and older. And I think that has been very helpful for people to feel more comfortable doing it. And once again, just having the tool, having a physical tool as opposed to asking the questions, and then being able to use that in discussion when you're meeting with a patient was very useful. And I think that helped people also feel more comfortable eliciting further discussion. I had no doubt that people were asking questions, but I think after they got the answer, they kind of just moved on. So it was helpful to have that tool to kind of elicit more discussion and, hey, tell me a little bit more about your answer here, and just having something for people to kind of base their discussion on.
Cool. And I guess I just want to highlight before we move on to the next group, something that you mentioned in passing, but I think is really important. So the difference between doing this in primary care and specialty care or behavioral health is that primary care doctors have a long-term relationship with someone. So they may be more apt to give information, as opposed to, there's lots of evidence showing that like the first time you see someone, they may not give you the full information. So I like the idea that you then tried to push it out at multiple visits, because we definitely have lots of reason to believe people might be more likely to give information at subsequent visits than initial visits. So so cool. That's any other comments you have about barriers or suggestions for others? Anything that specifically worked real well? This is your chance.
Yeah, or if anyone from any of the groups that are on, after hearing what the hospital team did, if you have any questions for them as far as how maybe they did something, implemented something that maybe you're thinking about doing at your facility, or if they made, a good point about something specific, please feel free to ask questions or comment.
So Mark Levan here, and my question was really about motivational interviewing, because I know that having a good foundation here is pretty important. I was just curious about the kind of training that your folks had prior to taking on Sbirt, or if you did anything to sort of get people up to speed on some of the MI techniques.
Many of our clinicians had a strong foundation of MI, but we also did a large group training at the hospital focusing on MI, which I think was helpful for some clinicians, perhaps kind of getting back up to speed if they had been out of touch with kind of MI tools. But I think that initial meeting that we had, it was an all-day training. We had other specialists. We had social work department here as well. And so I think that was really helpful. We had, very useful discussions and role play for people to practice their MI skills. And so that was a nice jumpstart to this whole process for our whole team. And then we kind of broke off as the learning collaborative group. And then, yes, Taylor has brought it up at almost every meeting that we've had. And so we, provide the opportunities with Cognito and with kind of case discussions and other things that we've been able to utilize to help with the MI.
Thank you.
Any other questions for this group before we go on to adolescent medicine's presentation? Okay, doesn't sound like it. I'm just trying to see, I'm looking at the list to see if we have anyone from adolescent medicine on yet. There is a phone number, it looks like someone called in from. So if anyone from adolescent medicine is on right now, could you please let me know so that I know whether to pull your slides up or not.
We have a nice set of slides from adolescent medicine, but no people yet.
Okay, well, I think maybe we could go on to the next presentation. If the next one would be water dam. If you're okay with that, Dr. G, would you mind going now? Or
no, I don't have a problem at all, and I don't have slides. Unfortunately, I wasn't that put together to do that. But
slides.
Okay, so hopefully without pictures it'll be okay. But I'm actually one of the pediatricians. We're at a primary care setting in the South Hills, rather large primary care setting with 2 sites. The thing about, I think, primary care is that it's really more of a preemptive strike. And if we're doing our job in the right way, we can see kids before these issues come up and hopefully prevent these issues. So to me, education is very imperative. But we also need to understand, and I think that's where we were lacking in the need to tease these issues out. I mean, especially primary care has become crazy with COVID and with everything else. And often it's a lot easier if you walk in a room and you're just like, okay, we're doing great, let's go, rather than actually asking the right questions, because then it makes things a lot more complicated. But also because we need to tease these issues out, a lot of these kids aren't aware that things are becoming a problem, and they're not aware that they're self-medicating or even becoming addicted. So I think asking the right questions is incredibly important to sort of prevent them from having to go to these higher levels of services if we can catch things in the beginning. So we're a little bit unique in that we were already screening using a tablet, and our screening was involved the PHQ-2/8. So it in CCP, they didn't like the 9 because of the suicide question, was a whole other story. But, you know, basically if you blip on the PHQ-2, then you automatically fill out the 8. We do have the 9s available in the office that I use frequently as well. And then we were also doing the S2BI and the craft as part of that tablet. So that was getting done for everybody 11 and older already before they went in the room. But what I realized was that a lot of people really weren't sure what brief advice and brief intervention was. And so we were doing all this screening, but we weren't exactly sure what we were supposed to do with it other than have a little conversation, which there was also a comfort level issue with the whole subject and not knowing what to do with that information. So that's pretty much what I focused my attention towards. So in the beginning, I encouraged Cognito. There was some take on that. Some people I think did some of it, but even the people that did some of it, it seemed to help. The physicians kind of share an office that is a little bit small, so there's a lot of conversation, and I think sometimes just having the conversation about motivational interviewing makes other people want to do a good job as well. So I actually, in addition to encouraging Cognito, because I knew I was reaching a point where I wasn't getting any more take on that, I just made it more part of the conversation. I talked about it more. People would start asking me questions about, what do you think about this? I would try to offer that advice, and I'd do it in a way that I felt excited about doing, because then that makes people feel good. And then we would discuss challenging situations and discuss successes, which I think was also a really helpful thing. And you know, pediatricians are an interesting sort. There's a lot of personalities in my office, and I love them all dearly, but everybody kind of feels like what they do is the right way to do it. So it's hard to change. But I think by discussing some successes, it makes other people feel like, ooh, I can do that too. So a lot of it was just having the conversation. The other thing we did is I have a kind of stack of folders where I have PHQ-9s and Becks and Scareds in several kinds of forms. And I had actually gotten a form from Adolescent on vaping, which I had in there too, that a lot of people were starting to go towards. So you guys were nice enough to get me one on marijuana. And that's in there as well as the substance abuse screen, because that's only done at a well check. So we have those available if people come in, you know, for other situations. And just having them sitting there in front of me and people coming in and getting them, I think having that available has allowed a lot more use and a lot more attention to that. There's also on those forms like community resources and internet resources and things to seek help. So that kind of helps that whole situation. I also posted on my bulletin board the whole weaning off of nicotine with patch and gum and things like that. Although I kind of need that updated, because now people are doing this different than just the pods. They're doing these things that they buy differently, and I don't vape, so I don't really understand that. So I could really do with a little bit better scale. Because really nobody here was comfortable, including myself, with knowing how to do that if somebody really did want to quit. And I think when you send them somewhere else, they're less likely to follow through. Whereas if they're in the pediatrician's office and the pediatrician's like, hey, you know, I think we can do this, they're much more likely to say, oh, well, this is something that's okay to talk about. And then on a more personal level, I actually did quite a few things, and I think this has been a really useful exercise. So I've kind of added a lot more information at my well visits. So especially the middle school kids, I've been starting to open up a conversation, even the ones that are deer in the headlights. It's like, hey, you're going to see a lot of vaping, you're going to see this. And I kind of talk about the harmfulness of nicotine and marijuana in younger people with a developing brain and all these things. And the mom seems super appreciative that you're like bringing up this conversation and you have this kind of scientific base to kind of like, you know, explain it. I've also started adding a lot more information about the aerosolization with vape pens and COVID and everything else, because I think that that's an important conversation to have. And I myself became a lot more aware of how the kids that are self-medicating with marijuana and we're trying to treat them with an SSRI, it's just completely like not helping each other. And just being able to have that conversation with a lot more information and a lot more facts And a lot of kids now, I say to them, look, if you're starting to feel like you're using these things to feel better, there's a lot safer ways to feel better. And I really need you to come to me and talk about it. So I think when you give them something educational and something to think about, and they also know that they can come to you if there's a problem, it seems to resonate better. And then we're really fortunate because our embedded therapist now that we didn't have because Barb left, and then we got Shannon, but Shannon's wonderful with substance use issues and teasing out the use of that. And her and I have been able to work really well together in collaboration with kids that she's trying to treat, that I'm also trying to figure out as well. So basically places to go forward, I think just continuing to talk about it and increasing the comfort level of people in the office. An update on the nicotine withdrawal. I think I'd really like to have an alcohol handout as well. So I don't know if that's something that we could do. But I think that that would be super helpful to have, just because I do find that a lot of people are going towards those. The one other thing is that I would really love, as part of the information I have on transition to college, but a similar kind of thing, I would love to have some substance abuse videos. I've had people actually ask me, do you have any videos about this? Similar to what I'm doing with the college transition, something short but informational. And I feel like that would be an awesome place for people to go, because the problem with the handouts is I think the kids are like, well, you know, the parents are like, why are they handing my kid a handout on vaping, right? So it's kind of hard to just sort of put that in their back pocket. Whereas if there's a place for them to go and watch information, I think that would be a lot better. And the people that I'm working with, the data collection is phenomenal. So I just, or even links, because I'm starting to try to link towards other kind of adolescent initiatives and things like that, so that people can help each other. So anyway, that's where I'm at, and that's where we went through. And I can send you this in writing if you'd like. I'm sorry, I just have scratch paper.
No need. I was taking down some notes. That was great. Yeah, I think that updating the nicotine information makes sense. I feel like it's getting harder and harder to figure out the equivalents anymore. I know that I had one of the psychiatrists at Pine Center had a patient using like a type of we hadn't heard of before. And so I was trying to find online what the equivalent would be. Of course, it was like you couldn't find anything. So I actually emailed the company and asked them, like, what would this be equivalent to? Like, I just pretended like I was using it and I needed to know. And they were like, it's just complicated. There's really no way of saying. And I was like, oh, that's horrible. So yeah, I think it's going to get harder and harder the more brands that are out there and the different sizes. And then there's there's nicotine salts now, which are even more concentrated. So, but I think that still an update to that makes sense. And about your videos, could you send me a link to what you have, like what you've been doing? Because I'd like to see what that looks like, and maybe give you some ideas as far as things, because you said there's no substance use ones on there yet.
So right now we just have college transition, and we're in the process of we've shot video for these COVID videos to go along with the college transition, because we got a grant from Beckwith to do that. So those are being edited now. And then the actual ones are actually going live like tomorrow, I think. So I can send you that link as soon as that's up.
That's awesome. Yeah, and I'm not sure if you've heard about the Smart Choices parent series that we've been doing. We sent an email out to all the parents of kids at CCP between 11 and 20, inviting them to attend this webinar series. So there was a 4-part series, and we did the first 3 already. The 4th one is tomorrow evening, but we've been recording them as well. So
okay.
We're going to get links to those videos put up on the CCP website. So that's something too, if you have parents that would like some information about helping their child when their child's using substances, you could direct them towards those videos.
Okay.
There's this workbook for parents called the Parent 20-Minute Guide. And it breaks it down into 4 different parts. And so we did each video on a different part from that guide.
Awesome.
So,
okay.
yeah, I'll
Good.
definitely share that information with you, the links and everything.
That would be great.
First 3, I just need CCP to like actually put them on the website. I don't know how they do it, but they will. I'm sure it'll eventually get up there. I did try sending people just the links that I have, but it seems like when they try to open them, they're not working. So I think somehow it needs to get something on the back end needs to get put up so that the links are usable. So
that would be awesome. Thank you.
Yeah, you're welcome. Yeah, I think that you know what you're doing, talking about MI and I think you mentioned you were trying to get more people at your practice to do cognito, but there was some struggle there with getting interest, it sounded like, but talking about talking to kids about substance use and making it a positive thing, and talking about the successes, I think really, is probably helping people, even though it might not seem like people are jumping to do cognito, but I think every time they kind of hear that, it gets maybe.
But I think though, I've seen a huge difference. I've seen just in casual conversation that, somebody will come back and say, oh, somebody who I never thought will come back and say, oh, I found out this. So I asked how likely it was that we'd be able to cut it back. And we're going to see him again in a couple weeks. Like, I'm hearing conversations that I never used to hear. Yeah. So I do feel like it's successful. It's just, I think the biggest problem with cognito is the time. People are so pressed for time right now in primary care that I just think it's so hard.
Yeah, I would definitely see how that could be hard, but that's awesome that you're having people that wouldn't have had the conversation maybe a year ago now having conversations about cutting back or harm reduction.
Oh, huge changes.
Back to follow up. That's a big deal.
Right. Huge changes. Like, I'm talking about people that just didn't like teenagers. I don't mean that, but I shouldn't say that. I mean, obviously it's not that they don't like them, but it's frustrating, right? It's like a frustrating age. And I think that I'm seeing them embrace it more than just frustrate with it, if that makes sense. And I think part of embracing it is just feeling like they can do something.
Yeah. Yeah, because it's before, maybe they had some of this information. It might have been one of the more difficult subjects to talk about. Not to say it's not difficult still, but maybe now that they are armed with some information and some strategies, they might feel like, I can do this. I can talk to them about substance use.
Plus, I am a huge trendsetter, so I
yeah.
Can you speak to a little bit to sort of COVID and how it impacted how the practice interacted with teenagers and sort of what your goals are in this summer going into fall season for well child visits and things like that?
You mean just in general?
Yep.
So yeah, it's been really tough, right? Because we're seeing a huge uptick in mental health issues. We've had the kids with social anxiety have been more than happy to do everything at home. And then the kids who are more social and outgoing are the ones that are really struggling now. It's been this complete flip. But then again, when we do get back into some semblance of normalcy, I feel like that social anxiety wasn't dealt with. And so there's going to be this whole other side of things. We are seeing kids, but we can only bring in so many at a time because of the cleaning. And so it's, I actually, because of my interest in that transitional age, I actually communicated with a lot of the kids I identified as seniors, and I made sure they had everything ready because some of them are going, some of them aren't. It's like a big mishmash. So we're catching up on our well visits. I mean, that is getting there, but I think that we've had so many different responses to COVID, and it's just so important to ask how they're dealing, and how things are going with it and what the plan is for school. I think the hardest thing right now is we're going, no, we're not going, and it's like everything changes on a dime. And, then it's like within a family, there's medically fragile people, so you can't go, but they feel like they need to go for social, and because they're a visual learner, it's easier for them to be in school. So there's a lot more questions. There's a lot more kind of talking things through and making sure that, we have a plan for the fall, making sure that the socially anxious kids know how to identify it when they do go back. It just looks different here. We have no waiting room. We have no, we can only see 3 an hour per practitioner because of the cleaning. So we have to work longer hours in order to get our patients in order to pay the bills, and in order to see who we need to see. So it's been a whole revamp in all of that. I think we're doing it safely. I think we're doing it well as can be expected, but I am concerned about the mental health of a lot of these kids. So.
Yeah, especially with the social isolation, and then any family that's struggling financially or that has other mental health or interpersonal.
Very much so, or families that it's not a comfortable home environment, and then these kids are home learning, or my ADHD kids, it's so hard to learn online. I mean, so hard. So it's been a challenge just trying to help them and work through it.
Well, I want to thank you for keeping your eye on the ball related to Sbirt through all of this, because I think, we know kids are going to be at increased risk, even though that first couple months of COVID, everybody was sort of home, and there was this impression it was a decreased risk for substance. I think that we saw over the summer definitely a lot of use, and a lot of use among families too. So thanks.
Yes, and it's amazing to me, and that's another thing I've learned through all of this, that if you ask the right questions, it's amazing to me how many teens are smoking to calm down, smoking to fall asleep. It's just, you got to ask. And if they feel like it's okay to talk about it, then it all just spills. But yeah, we have seen a lot.
Yeah. And I guess the other, as a side before I forget, in terms of the nicotine replacement, I would not hesitate to overshoot in terms of nicotine replacement, because you can always decrease, right?
Right.
If you undershoot and people have withdrawal symptoms, they just disappear. So I think it's a little different than a lot of pediatrics, where sometimes we try to go low and slow. But if most likely all of these other types of nicotine delivery systems are giving you more, not less. So
my biggest challenge with that is that they don't want the parent to know. So how do you get this for them without their parent knowing?
Yeah, that's the biggest problem.
Especially if they're under 18, it's impossible. With the older kids, 18 or older, they can purchase it over the counter.
Mm-hmm.
It's not around. Or if they call the state hotline for smoking cessation, and they're 18 or older, they can request nicotine replacement. And if they have it available, they will mail it to them. Then again, then it does show up in the mail. So I think it's discreetly packaged, though. I don't think it says anything about nicotine on the outside, but that's a good option too. If they had it mailed to friends or something that they're able to pick it up from, what they're more comfortable about. So yeah, under 18, that's really hard though for the
It's just frustrating, because those are the ones that you want to get off it. You want to get all of them off it, but if you can get them off of it before it's been too long, it's going to be a lot easier, so.
Yeah, and I called the PA quit line just to confirm that that they won't give it to under 18, and they said, they're not allowed to. They'll still do the free counseling sessions with them on the phone, but they just can't mail them the nicotine replacement, I guess, for whatever regulation or law they have to follow.
Right, and a big issue here is we still have a lot of parents that wouldn't recognize nicotine delivery systems if you even saw it, right? Like, it's not like finding cigarettes around the house, I think anything you can do to educate the parents, to say, have you seen anything like this? So the parents admit they've seen it. I know you're walking a fine line with a teenager, but a lot of times parents have seen things and they don't know what it is.
Well, that's why I think it's great that you did that video series for parents, because that probably talks about all that, right? So, I mean, I think, and that's part of what I was thinking is, and it's already been done, but I think it's great to have the information for parents, but then also to have information delivered to the kids in that format too, just because, like I said, I've had people ask, they're like, because they know I'm doing these things for other things, and they're like, do you have substance abuse ones? I'm like,
Yeah.
no.
What we didn't do in that was go through, I don't think we went through all of the nicotine delivery systems, like that nice little slide you saw that showed like how some of them look like lipstick. You know,
Yeah, we didn't, but that makes me think that maybe we should do something even like a shorter video, but showing the different types and what they look like. Because the parent series really just focused on skills as parents when you know your child is using. But it's also, I think we have some people joining that don't have a child that's actually using, but they just want to know what to do if it happens.
Yeah.
But the first series was helping with understanding, so helping parents understand why their child is using, and then helping with self-care so that the parents are taking care of themselves throughout the process, helping with words, and helping with actions. So those were our 4 topics. So
I feel like if we put some things together, because I know for kids, and that's why we're doing them the way they are, like for specific topics, they like short stuff. So I think if we could manage to do something like that and then have it, you know, have everything that's accessible as far as the parent information, and maybe do something on recognition, I think that would be great. So, all right, I will send you things as I have them available, but they should be this week.
I guess the other thing that I often ask parents, have you ever found something around the house and you're not sure entirely what it is? Because it's amazing how many people say yes, and they don't even think like, oh, it could be a nicotine delivery system, because parents haven't ever been exposed to this stuff. So, but that's great advice. We'll think about, you know, something little, something short that just at least expose parents to what these things are. So, because if they come to you, that's like half the battle, right? If parents come to you and say, hey, I found this.
Right.
Once the door's open,
right,
a whole bunch more.
Right.
So, great.
So I got an email from Alex at Adolescent Medicine. She is seeing patients at Schumann, and she's having internet connection issues from Schumann. So she's gonna keep working on trying to get in, but she may or may not be able to call in and present based on that issue. So I think we were close to break time anyway, 10 to 10:15, I believe. So I think now would be a good time to break and then come back at 10:15.
Sounds good.
Sounds good. All right. Thanks, everyone.
Thanks, everybody. We'll see you at 10:15.
Mm. Mm.
Shannon, it's 10:15. Should we get things started?
Sure, yeah, that sounds good. I'm just going to put my video on, and I think I'll share my screen again. I'm looking to see if Alex from Adolescent Medicine made it on. I don't see her name. Alex, you don't happen to be on right now, are you? Okay, doesn't sound like it. Maybe she'll get in.
Yeah, I don't see anybody in participants.
Yeah, I've heard the internet connection. Well, all thing that involves internet at Schumann is bad from what I've heard. So, okay. So then the next group would be Safe Harbor that I have scheduled to present. So are you guys, do you have slides that are going to go along with your presentation?
We do not have slides, sorry.
Oh, no problem, not at all. So I won't share my screen, then I'll just keep it like this so that we can see who's talking, so.
Fabulous. I wanted to start off with, to get the teenagers' attention, we should all create some TikTok videos, which I know nothing about, but
I know.
they're all so.
I wouldn't have the slightest clue on how to make one, but yeah, I hear they are quite popular.
Right. So maybe we recruit a group of kids to make some, I don't know, but I'm just saying.
Yeah. To show them the different vapes are out there, or for the, well, I guess for the parents, I don't know if they'd watch TikTok, but who knows? You never know.
But just thinking other platforms to get the kids and whatever.
Yeah.
Okay, so to start off, like, I'm not going to repeat a lot of the things that other people had said about, you know, obviously we all have different, you know, agencies, different parts where we work, and it, you know, it all affects differently. We're mainly mental health, so easy to fit in the Sbirt stuff, obviously. We've been way slower to start off, though. I'm hearing some of these other people talk, and we are way behind the curve. So, but we're moving. So we're moving forward, and that's what matters. So first of all, successes are definitely getting the trainings, doing the cognito, you know, having our meetings with Shannon, and then trying to kind of spread the training out to others within the agency. We actually have a internal training scheduled for next week to reach more of our therapists and stuff. So, so we are really moving on that. As of right now, mainly it's been Lauren who's on the call, and she is our intake specialist. So she does intakes majority of the time. So she was like the easiest person to catch new people coming in, especially when we were still sort of totally focused on kids. But then that's going to branch out, but I'll talk to about that in a minute when I talk about the future plans. Otherwise, it's really just getting the staff, you know, more experienced, more comfortable, like other people had said, about just all the drug and alcohol type stuff, the language, knowing what certain things are, certain terminology, all of that stuff. A lot of people are uncomfortable with that. You know, we work in mental health, so like all that stuff is comfortable, but that would be uncomfortable to other people. But the drug and alcohol, for whatever reason, kind of holds people back sometimes, especially with the younger population, for sure. It's a little more easier to have the conversation with an adult versus a teenager. And just like someone else had said earlier too, about the really young ones, like the, you know, 11, 12-year-olds, like that's even more like we all just kind of think like, no way, but we all know obviously it does happen. So I think the younger they go, the less comfortable the conversation probably is too. But as we all know, it could be any kid from anywhere, you know, at any age. So we do have to like broaden that more. As far as some other specifics, Lauren is actually going to talk a little bit more about successes. So I'm going to turn that over to Lauren for a minute.
So, yeah, so with the successes, I actually was keeping track of the amount of intakes that I was doing, and I was able to, over the past like 5-6 months, do about 33 intakes with our adolescents, focusing on that 10, 11 to 17 age range. So I have been able to do, had one opportunity to do an actual intervention, which was good. And then with the successes, we've kind of snowballing into our challenges has just been getting to have a positive screen, someone be able to move further with the intervention. But our numbers for completing adolescent intakes are increasing each month. So I'm kind of keeping track of how many intakes I'm doing and what kind of falls into that adolescent population that we're focusing on for the intervention. So the numbers are increasing each month. It's just, we really need those positive screens to come into play.
That's great that you have 33 screens. That's like that's a really good amount because it's just you doing the screens at the intake, right?
Yes, I mean, I don't do, I can't say I do 100% of the intakes, but that's just kind of what I've done. I would say I do majority of the intakes. So yeah, I think that that's really great as well.
All right, so I'll take back over with challenges and kind of like what Lauren was talking about. She does the majority of the intakes that come in. So we usually, outside of COVID, have a walk-in intake process. So it's literally just come in and do your intake. But with COVID, they've been scheduled. They're mainly, telehealth. Some are in person, but very minimal. So that actually allows for more no-shows, which we didn't deal with before in our intake because it was really just whoever came in got seen. So now we're back to like a no-show issue and whatever, because they just don't answer the phone or whatnot. So that's just been something different to deal with COVID. COVID is another one of our challenges that we had listed. Just pretty straightforward in the sense that, telehealth is a little bit harder in every aspect. It's harder with the kids. Usually a parent is sitting right next to them, as part of the conversation. And it would be the same for the most part in office as well. But they, obviously are not going to probably be as forthcoming with information when mom's sitting right next to them or whoever. So that's definitely a huge thing holding back. So we're hoping maybe once we're face to face, we can, meet with the parents, get all the info we need from the parents, but then meet with the kid for a little bit and be able to ask those questions one-on-one. Which would then more likely lead to more positive answers and being more forthcoming and honest. And again, so as far as the overall intakes, so Safe Harbor also is in many satellite locations within the community. So we are in lots of schools. So we do a lot of intakes in schools. Those other therapists have not been doing that as much with COVID. Obviously, we haven't been in any schools. Referrals are still coming through, like new intakes, but not nearly the number we normally would have. So hopefully with the school year, and who knows what that's totally gonna look like as well, because every school district is doing something different in the sense of their plan. It looks like we are still gonna continue to probably mostly telehealth in most of the buildings. They're not really gonna even if they're letting the kids come back in any capacity, they're not really letting outside people come in. So it's still gonna be a huge barrier for us. But the training I mentioned earlier, we are going to be training that handful of therapists that go into the schools. So that's our whole purpose as part of our future plan, to train this handful of other people, make them comfortable with doing all of the assessments and things. And then they're gonna catch those teenagers and they're gonna catch all those kids right off the bat. The other part is too, for us to revisit it, not just, obviously do it at intake, but then also do it a little bit later once the kid gets comfortable, once you know them a little more, plus once you have more kind of one-on-one time with them as well. So that's part of our like sort of future plan. But I kind of skipped over. Lauren, did you have more challenges?
No, I just want to reiterate, I mean, I think definitely COVID has been a big challenge and just in general, just the population, not having like a high number of adolescent population just as of right now. And I do know just with my history with completing the intakes, we do have times through the year where our volume for an adolescent population is very high. And then there's times where it's not. And sometimes the summer months where we're kind of at right now is not very high with the adolescent intakes. Typically closer to when school's starting, the beginning months of school, we tend to get a little increase in adolescent population. So I'm hoping, coming in the upcoming months, we're getting more adolescents that are coming in seeking services where we can get some positive screens in there.
Yeah, and we really expect, you know, once kids sort of get reconnected, at least in some fashion, face to face with school staff, that there's going to be a lot of stuff getting caught, and a lot of things coming out that they need, you know, help with, need to talk to someone, whatever stuff. But with them being home and being virtual, they haven't had that interaction with the adults. So hopefully we expect it to kind of really jump up a lot, and more than usual just because of COVID and stuff. All right, as far as future plans, like I'd mentioned, to get staff trained, doing more of the assessments. We actually, so part of our bigger plan, our initial plan is to train another handful of therapists, the ones that are more likely to have more interaction with teens and stuff. And then complete, once that's done, then to branch out into all therapists. So we have approximately like 30 outpatient therapists here. So we're only getting a little bit of them. We're gonna eventually get all of them. And then after that, branch out into other, we have some case managers who are specifically see kids. So we're gonna get like those couple people and kind of keep branching out in that way, to eventually hopefully get everybody is our overall goal eventually. And then as far as, you know, adding adults too down the road, I think we're very internally focused on just the kid piece. But then eventually, you know, I think then everybody will be comfortable with the process in general, and then we can kind of branch out and just kind of add the adults as well. We do currently, I mean, just like everybody else, I'm sure we do currently screen. We've screened forever, but we've definitely become more specific and more concise with what we ask, how we ask. You know, like somebody had mentioned earlier, it was, you know, everybody asks differently. Sometimes it's a super broad question. Sometimes it's more specific. I would say as a whole, we've definitely found if you ask more directly about something, then you will get the answer versus an overall question. So I like the more specific part of it for sure. As far as other future, I also wanted to mention, we have addiction medicine services here within our building, in our main building. So we always have access to, you know, people that have more of that knowledge and stuff. So if somebody runs into something they're not sure how to handle, what to do type of thing, we can easily talk to someone very quickly. Also, I've been in talking with the supervisor of that program, and she's putting together a training for, you know, similar to what Shannon was talking about earlier with the different types of substances, kind of just the things to look for. She already has stuff like that probably put together. She's just going to put it together for us. And then also she gave me like a list of all the community resources. So for adolescents and adults, so that we know where to send them if that is where, you know, goes to. As far as, I think that was pretty much most of our future plan. Lauren, did I forget anything?
I don't think so. I think you said a lot of it, yeah.
All right, I think that was most of our stuff.
I think that the partnership with addiction medicine in your building, you know, talking to them, getting some trainings together, things like that, I think that's really exciting that you have them there. I didn't realize that you had, you know, someone so close and accessible. So I think that that's a great resource. And like you said, even if, you know, they're not the right fit, maybe for the person, they need to go somewhere else, they have the community resources that they can share with you. So I think that that's great to have them moving forward. And I think the schools it's very exciting that you're going to be screening kids in school, or, you know, whether it be through a virtual means or in person. I think that that's really exciting. It reminds me a lot of what Presley's doing too, which they'll be, I think, presenting next. I see a lot of similarities between you guys. And your two groups have been on the monthly calls together, so I'm sure you've seen that as well. There's some similar initiatives going on.
Right.
And
probably
you
one of the biggest things one of the biggest things we run into in Erie is we're smaller, obviously, and we don't have as many resources for adolescents, like in general. We have our own internal, but then really we have Pyramid here. And that's really the only other true option. All the rest is all for adults. So we're really limited in that sense. So it's good that we're screening, we're doing all this stuff and moving forward. But yeah, the lack of resources is pretty obvious though.
Yeah, well, it makes Sbirt even more important, right? Because and most adolescents don't even qualify for some of those services. So
Right.
it's sort of, that makes it even more important to feel like you have something in your toolbox, or else you're not going to want to ask at all. Remind me, Safe Harbor has like a wide variety of services and levels of care, right? Like I think you have in-home services and.
Yes. So we have in-home services. Like I mentioned, we're in a lot of schools and stuff, regular outpatient therapy. We have peer, we have a crisis residential unit, but that's adults only. We have crisis services for Erie County. We have blended case management. We have AMS. Whenever I go through the list, I'm always like, who am I forgetting?
I'm sure you have lots. You know, so what we've seen down in Pittsburgh, we're starting to see an uptick in people needing intermittent and higher levels of care. That's unusual for the summer in adolescents, just FYI. So we definitely are seeing more people using our IOPs and partials that are adolescents than we do usually in the summer. So, you know, I would wonder if anything you guys can do to hook up with your higher levels of care, because, you know, the next place they go is outpatient. I guess the other thing we're seeing is that just a lot of families that are struggling for other reasons. So it's not surprising to me that you're seeing then, now that you need to schedule, families that are struggling either for psychosocial reasons or financial reasons, you know, they have more trouble following up and scheduling, or even using internet. Have you guys run into trouble with internet for people? I'm just wondering what it's like up in your.
Oh yeah, absolutely. Part of that is, I mean, people just don't have the technology in general. They might have phones, but even the phones aren't compatible and stuff half the time if it's an older phone.
Right.
But yeah, we've definitely, I mean, we're doing video. We had a ton of issues with VidYO, of course. So that put a kink in a lot of things. At first, we were able to use other things, so it was great, and people were doing a lot of video. But then once we were only VidYO, we kind of, our numbers dropped for video for sure. But we still try. I would say majority is still by phone though. And we are seeing people face to face, but it's not in any near the regular volume. It's very minimal.
It sounds like you guys are struggling through sort of how to assure confidentiality.
Yeah.
Yeah, we've had to do a lot of explaining to people what that is.
Yeah, and people definitely do better with the video sessions. I think from the majority of people, definitely it's a better session than just the phone. But yeah, and I think at this point now with COVID and doing this for so long, that it's even hard. You know, the challenge is just really getting people to buy in and really want their services and stuff. It's just become harder and harder to get them engaged.
Interesting.
But yeah.
Well, it sounds like you guys continue to press on. So that's,
we do.
That's the important part, right?
Yep, we do.
Anybody else have any questions or comments? Sorry, Shannon, I jumped in on you.
No, that's what I was going to ask. If anyone had a question for Safe or comments. Doesn't sound like it, but we'll have an opportunity at the end too to talk. So if anyone thinks of anything. Okay, so then Presley, you guys are up next. So we have Mark on the line and Chris, I believe. Do you guys have anyone else with you?
I think it's just Chris.
Okay, sounds good. I'm just going to share my screen and pull up your slides.
Did you get the most recent one I sent you right at the beginning of this?
You know what? I saw that come through, and then I meant to put it in here. Let me just I'll share my screen. I'll go to my email and then share my screen and then pull it out of there if that works for you.
Sounds great.
Oops. There.
You know, anytime I present anywhere, there's usually a technology problem. And I kind of helped create this one this morning. So I figure if we get it out of the way right away, then we'll be good.
Good.
Just get it out, take care of it, and then we're good.
Yes. Oh, keep messing this up.
And I apologize because I had tweaked a little this over the weekend, and I had to send Shannon a PowerPoint on Friday, and so it's a little different now. But
oh, no problem. This is the new one, right?
This is, yeah, it has Sbirt right on the front.
Oh, I was wondering what that was.
So it's kind of a joke, and it's sort of funny. Again, I'm Mark Levan. I'm from Preston Ridge, and Chris Caprini has also joined me too. He's a supervisor in our Crisis Stabilization Family Preservation Service line, the crisis group in our Beaver County office. So Preston Ridge, we'll talk a little bit more about that, but why is Sbirt on the front of that? Well, it's sort of a joke, and at the same time it really isn't, is that when we introduced Sbirt way back in August, we had a lot of folks, even in places that were pretty high up, that didn't know what Sbirt was. And so we frequently heard people talk about the Sbirt thing that's coming around. And I had to really clarify with folks that Sbirt is actually a lovable sea lion or a white-coated seal of some sort that was a cartoon show back in 1985. They saved different animals from poachers. It was actually a pretty good show, but you can go back and look it up. I'd actually look it up on Wikipedia and find out what Sbirt was, but I did remember it being a cartoon. But as much as it's a joke, it was really sort of important at the very beginning that we sort of defined what Sbirt was. And it sort of spoke to knowledge that we had at Preston Ridge about different programs around substance use, is that folks had not heard of Sbirt before. I had been fortunate enough that I had been introduced to Sbirt a few years prior to this collaborative, because we had worked closely with CalU to try out the Cognito program, which is where we first got an inkling about what Sbirt was, and then really just was fortunate that we had this opportunity with the Smart Choices Collaborative. If you go to the next slide. So just a brief, I don't talk too much about Preston Ridge, but we're getting bigger. We have about 70 programs, and we sort of grow and shrink every day. Sometimes we add new programs, and sometimes some disappear, but we're in 6 different states now. We really have service lines in the community-based arena, residential education, treatment foster care has become really big for us recently. And then we've really been starting to work on our external consultation and training department too. Where we were focused out with Sbirt, at least initially here, was in our community-based services and mainly in our family preservation and crisis stabilization service lines. Interesting type of program. If you haven't heard about it before, really what happens is we get our referrals, and Chris's program's a little bit different. They were really the first crisis program. They've sort of developed into a little bit different, but just to give a general overview, our crisis programs are really referrals we get are typically from CYS, and what is happening is we identify that there's a family that could potentially become part of the social services system or part of the dependency system, and crisis stabilization is designed to sort of divert folks away from being part of CYS and really get them involved in mental health services. And so it's a quick service, short term, with a goal of getting folks into something like family-based mental health. Try to assess what's going on, stabilize the family to the point where they can participate in mental health services, and then this often prevents long-term CYS involvement. And we've been pretty proud about this program. It's expanding pretty rapidly. We have programs in Beaver County, Washington, Westmoreland, York, and Fayette right now. And our goal was really to try to get all those programs on board with Sbirt as we move forward. Just as a short note, I said our treatment foster care program has been pretty big for Preston Ridge. It's always been a big program, but we recently are pretty proud to say that our pre-service training for treatment foster parents is the only evidence-based program. We just recently got notification from the California Clearinghouse that our program is evidence-based practice. And so we're doing a lot of work on training folks on that. So we can go to the next one. So more stuff here, 10,000 people served each year. This stuff's taken right off our website. 1,100 employees. Re-education, if you haven't heard about it, it's a philosophy developed by Nicholas Hobbs. And the reason why I even bring it up here is we feel that like Sbirt really fit in well with our mission statement, our re-ed philosophy about, whatever it takes, great success for children and families. And there's the link to our website. We just redid that this last year. It's got lots more information if you're interested in hearing about Presley Ridge. So we can go to the next one. So interesting that we got to be a part of the Learning Collaborative. Really what happened was that a couple of years ago, Presley Ridge as a agency-wide initiative was to try to become better at co-occurring disorders as a strategic goal. And we had started with Allegheny County and Case Western Reserve University Center for Evidence-Based Practices working on this. If you haven't heard of these, the dual diagnosis capability in mental health treatment or dual diagnosis capability in addictions treatment. It's an assessment to see how well you're doing if you're a mental health treatment facility in dealing with addictions, and if you're an addictions treatment center, how well you're doing with mental health. And the idea is to try to boost the side that you're not normally working on. And so we started working through this program through Allegheny County, and a sort of parallel process was occurring is that Dennis Daly, who is the former UPMC Director of Addiction Medicine, came on to Presley Ridge as a consultant to help us become better at co-occurring disorders. Because Dennis Daly was involved, he sort of gave me the notice the night before the collaborative was going to start that this was going on, and I would get to go to Oakland at 5 o'clock or at noon on a Friday to be a part of this. And that's where we picked this off, and it's been super helpful. Our biggest thing with Presley Ridge was that, we were largely a social services agency that dealt in mental health. And so we were often sort of had a line where SUDS, substance use disorders, were sort of off limits. They weren't addressed in the same ways. And I know that's problems that everybody's seen, so I won't harp on that too much. Our goal really is to get people to be more prepared and comfortable with dealing with substance use disorders, not necessarily doing the treatment, but providing what we can. And really, we're finding that people are becoming more comfortable, not just in the agency, but everywhere, that people are able to reach across the lane there and work on both sides of that. So next slide, please. So after the Sbirt initial kickoff meeting, we were fortunate enough that we had a train-the-trainer had happened, and I thought this was really pivotal for Presley Ridge, and that we trained 9 staff at that point in time. And the interesting thing for me is that we had folks from our training department, from the clinical department, we had a couple of supervisors, Chris Caprini being one of them, participate in that training. And that really was probably the best thing we could have done, because the result of that was that we all of a sudden had this group of people who were educated in the Sbirt model, who sort of dispersed all across Pennsylvania and other parts of Presley Ridge, that now had this knowledge. And so there's a twofold thing there. Is one is we get the training out, but two, we sort of have these regional experts now in the model that allow for us to be able to sort of consult about how people are practicing and using Sbirt. So that was super helpful. Next slide. So just a timeline of what we did. So this is, and I think this is probably the part that was the biggest struggle for us, is that so we had 3 programs get trained very quickly afterwards. We had the Christmas break after we trained our trainers. It was in the beginning of November, but we waited until after Christmas to really put the training out there. So end of January, we trained 3 programs, York, Beaver, and Westmoreland. And what happened after that is we went into February and things got really sketchy with COVID. And as a result is that we really, although trained a bunch of people on this, we lost momentum very quickly, because we all of a sudden sort of were, like everybody else, in crisis mode, looking to see where we could best assure that we were doing our baseline services first, and then to add new things. I'm really proud of what Presley Ridge did during COVID. I think we responded really well. But part of that was us prioritizing getting folks used to using Zoom and telehealth. And so it did sort of put a delay in doing the Sbirt. But we sort of came back around, and we have this process in our training department called an ADDIE, and it stands for something, and I was going to look it up beforehand, but basically it's our way of adding a new training that's standardized training for all Presley Ridge. And so on 3.6, we started the process of making this part of our learning management system. So it's a standardized training for all folks could use at Presley Ridge, and our final version of that came out in May of 21. So we were training it ahead of this, but now we have a nice standardized version that anybody could access as a trainer. It's consistent. We find that, being consistent and fidelity, we need to do that. So our sort of foundation is in place. Once that training was set up, we got our other crisis stabilization program done with training in June. And the goal was, and you can go to the next slide, Shannon, was that we would have all the crisis programs using the S2BI and CRAFT and Sbirt to screen folks as of 7:15. And so, and again, I sort of say to myself, like, boy, it took a long time to get there, but we're there. And so we're starting to see that folks now are using the screen on a regular basis in all these programs, with the exception of Beaver, is using the Sbirt model, but they are involved in a research project using a different screener, the ACOK. And so they're going to finish using that, and then maybe somewhere down the road, they'll get to using the S2BI and CRAFT. But the point is that these crisis programs are now using the Sbirt model. We have 2 trainings that are going to come up very quickly here in the next week, week and a half. We'll be training our first family-based mental health program and our community and school-based behavioral health programs. If you don't know about CSBBH, it's a really interesting sort of service in that they provide therapy in schools. Currently, we're in Stowe Rocks and Oliver Citywide in Pittsburgh. But they also provide family therapy and some case management. It's a really nice sort of all-encompassing service that's really done a lot. And they're going to be trained next week to start using Sbirt as well. Our first education service line group to get trained in Sbirt will be the Johnstown Day School. And that'll be a big group, but it's interesting, as Shannon said earlier, is that so now we're going to have schools doing this. And these folks are very strong clinically. It's not a typical school. It's an alternative education program, but so they're clinically strong to begin with, and it's going to be a nice fit, I think. So we'll see how it goes. As I put this together on Friday, I went back to sort of look. We have approximately 75 people trained to do Sbirt, and that number is approximate for me because there were a few people who trained before we had this set up in our LMS, and so I have to sort of go back and look and see how we're adding that back in. But we have 9 trainers, 4 programs in Pennsylvania. And so we're growing with this every day now that we've kind of gotten momentum. Next one. So I jump right into sort of lessons learned here because this was, although it's just been a fantastic process, the best part of it was learning that there were some things we didn't know and we really need to figure out what we're doing with. So the biggest issue, and I think everybody sort of runs into this, is that we're sort of at the beck and call of what the state licensure boards and auditors and what sort of oversight committees we have working in our programs will tell us the type of screener we're supposed to use. And we've encountered the problem of having, somebody said we were using at one point in time 80 different kinds of screeners for substance use. That seems to be a really large number, but point is that we don't have in all Presley programs standardized screener for substance use, and it's really sort of a goal of mine to try to iron that out. But again, if a county asks us to use a certain screener, then we will do that because we serve the county when we can, we try to work with folks to say, here's some nice screeners we can use that'll get you these sort of results that tie into this Sbirt model, and we're seeing some progress there. The other issue we ran into is that we have several programs that are evidence-based practices on their own. And so they have a certain set of screeners and models that they want to use as part of to maintain their own fidelity. So we're going to have to sort of work around how we do that with those programs, but they're a small number of what we have at Presley Ridge. As I mentioned earlier, the COVID lockdown and the processes we went through was really poorly timed, not that anybody could really time it. For what happened here, because we had 2 problems. The first was we had training, and then because of COVID, a lot of things got put on the side, so the go live didn't happen until months later, and so we had this gap between training and actual use, which we did some things to help fix. But the other thing was intakes really slowed down in some areas too, because we find there was an interesting effect of COVID that folks not being in school sort of reduce some types of critical incidents that normally would have led us to become more involved in certain programs. And it just was a strange phenomenon that although certain incidents slowed down, we had other things going on. And so especially in the crisis programs, Chris can maybe talk more, Beaver was always very busy, but some of the other ones slowed down quite a bit. Zoom made practice a little difficult, and Shannon and I talked quite a bit about this, is that Zoom as a platform that Preston Ridge adopted only allows you to sort of be in breakout rooms. So you can come to these breakout rooms that are nice, but you're sort of in and out of them. And as a trainer in a large room, and I've had, done lots of trainings where we do practice, it's sort of nice to be able to walk around the room and get a feel for what people are talking about, and then sort of be able to guide people as you're going. That's a lot harder to do in Zoom. And so one of the things that we did, which I thought was really a good process, is in a couple of the programs we trained, and then we asked folks to go through the Cognito program. And then I went back and we actually did individual practice and supervision. So it'd be small groups of maybe 3 staff, a supervisor, and myself, and we would review practice with the Sbirt. I probably mention this later, but those folks who went through the Cognito program, and there was some people just for whatever reason couldn't get into it, time being one of them, there was a tremendous difference from my point of view as a trainer going through and practicing with these folks. The folks who did the Cognito program were light years beyond the other folks. It really helped quite a bit. It was a nice sort of fit to this, and really a useful tool, I thought. And anything else, we know that if you don't follow up practice and continue to consult to a certain model, it's going to drop off. So in places where we dropped off because of COVID, people lost skills. And so we had to sort of go back and refresh, but folks were able to sort of do that. The other thing we learned is that, so we do have some scenarios that Shannon provided for us and some that we actually came up with ourselves. We need to get a better menu because there are programs that are serving different people at different times, and some of the scenarios really need to be crafted better for practice to be more realistic to what they might encounter. Next slide, Shannon. So this is why I asked the behavioral health folks in the beginning here. This question is what I learned is, so a lot of the folks that I'm working with, there's a varied level of experience around motivational interviewing and interviewing skills in general. Not that motivational interviewing is the same as interviewing, but just a clinical assessment skills. And so what we're finding out is that if you have some sort of MI training ahead of time, you're going to be much better off to do that before you do Sbirt. Not that you can't, it just makes your skill level much better. So I think Preston Ridge really is starting to make some moves now to make MI more standardized and taught to programs. And like anything else, we have to start small and work our way up, but that's going to be something that's going to be helpful in the future. And some folks talked about this, and we ran into the same things, and it was nice to hear other folks talking about the same kind of problems. Was, the first and foremost is a lot of folks, when we're talking about coming up with some sort of plan that might involve harm reduction, is there's this sort of fear, this idea that we're being permissive by allowing somebody to continue some level of substance use rather than just ending it all. I think I had, one person, I won't bring her name up in particular, but she really turned a corner on this by going through this program. I remember her talking in the very beginning about, like, I can't tell a kid that it's okay to continue to smoke weed. If I know that kid's smoking weed, they need to stop. And, after doing this training and going through some other sort of things, she really came back around to the idea that, like, okay, so we really have to start somewhere, and progress is important rather than just trying to jump all at once. The other, same thing with the behavioral health folks is there. We got some folks who are saying this really is not my wheelhouse. This is not, how can this be useful? Is this really my job to do this? And I think those sort of attitudes ended fairly quickly because I think everybody knows now that you just can't work in a field where we're working with kids and families without having to address substance use disorders or any level of substance use in general. Another big one, and this is, we always try to look to make sure that folks aren't doing a whole lot of paperwork. We just know that folks spend a lot of time on that. And in our first 30 days, we have this tremendous amount of assessments and things that we do. And so when we brought this up, it was sort of like, so we're going to add yet another thing that we're required to get into electronic health record in the first 30 days. And so, again, I think folks really found that this fits in well with some other things. And so it's again, not very time consuming, and the actual skills used in Sbirt really help in assessing in other areas too. And then I talked about this border that people are really worried about crossing, about whether or not they're going into the realm of substance use treatment. which is sort of something we can't do because it really goes against our license. Fortunate thing there is I've just from my position been able to see that auditors, people responsible for licensure are much more comfortable allowing people to have some gray in there because we know that the crossover is big. And I think that's a real victory that folks are seeing it that way now. Next slide, please. So another thing we ran into is that the crisis stabilization service line is really relatively new for Presley Ridge. And so we were trying to get everybody on the same page with the types of trainings they have. Add to that, we're always sort of putting new initiatives out there. And it just so happened that this all happened, that we were doing Sbirt along with a lot of other trainings and initiatives at the same time. And so although that happened this time, I think that we have to always be careful about how we bring new things in when there's other things going on. It's just too much for folks to absorb all at once. And we need to make sure we sequence things so people have the right trainings in the right order. Sbirt, I find, really needs to be done after you've had some sort of foundational things, MI being part of that. But I don't want to wait too long for folks to get this because it's so important. But the good news is since we have a group of people who are now trained, it's more like rolling training now. So we're just getting new folks up to speed as we go. And Zoom is really helping with that because we can really do organizational-wide trainings to get people up to speed. Somebody else talked about this too. I think Safe Harbor mentioned that, so we have situations in a lot of our areas where we don't have good service providers. We don't have as many good service providers, and we might not have the same relationship with them. So that really sort of, especially in our rural areas, we find that there's really a limited access to people who are doing substance use treatment. So warm handoffs can be difficult. And so we really have to sort of foster our connections there. And that's happening, which is good. And I think this has caused us to become better partners and to work with people in a different way. I talked about skills dwindling. And the other part of this whole Sbirt initiative is that really looking at how all of our folks at Presley Ridge are onboarded as far as training goes. There is in Presley Ridge, we were really sort of all over the place when it came to substance use disorder training. And so as a result of sort of getting involved with the Sbirt Collaborative, we've now taken on another initiative here. But basically to try to get everybody the same sort of introductory substance use disorder training. So we're working with Dr. Dennis Daly to help us with getting something that we can have everybody have a part of when they start training at Presley Ridge. Next slide, please. So here's our plan. So the biggest thing is we're finding, and this is not necessarily, Sbirt certainly charged this up, but it's given us another reason to really move to the idea of MI everywhere. We really want folks to have some exposure to motivational interviewing in all programs, no matter what sort of things you're doing, because it's so useful, whether you're doing work directly with families or if you're working in supervision. It's just a useful communication style that really folks should have a good familiarity of if you're working in this business. I talked about the intro training we're going to try to do, but we're also, one of the things we're trying to do better at, and again, COVID really put a hamper on this, is the regular training and consultation based on substance use disorders and trying to help people get better at that. Education service line I had mentioned earlier, I think everybody there is now trying to get that Sbirt training in. It's going to be a challenge because we know that school folks, their ability to train is based on the amount of days and times they have open for training, and some of that stuff gets filled up really quick. But I think they're making a real effort to try to have everybody trained up in this year. And then all our community-based programs, I mentioned earlier, family-based mental health and community and school-based behavioral health will be the next groups to really start going through this. And then next slide. Good news with Zoom, that when we're talking about Zoom being kind of a problem, I found that there is a big advantage in that we can now do these sort of trainings and have everybody across the agency participate. The practice part we have to work on, but the actual training itself makes it easier for us to get it out to folks. We talked about monthly consultation. We want folks who are using MI and Sbirt to continue to practice it, because I know that people drift, it falls apart if you don't continue to reemphasize the skills. And then we now, I think, are at a point where all the crisis stabilization staff have been trained. And now as we bring in new folks, they will be trained. So we'll have this sort of rolling training that'll go on. And this will lead, hopefully, at someday for us to unify our screeners across Pressy Ridge. I think that there's a lot of advantage to that we can start seeing trends because we'll have similar things to sort of pull data from. And then last and most importantly is that we're going to have to make yearly or semi-annually refreshers for trainers to make sure that we're staying on course as far as fidelity. I think I might have one more, I'm not sure. Nope, that was it. So a lot, and I moved quick a little bit there because I knew I was going last, but what questions do you have? And Chris, if you have anything to add, sorry.
Yeah, no, for us, we were kind of the first and the oldest crisis program, and we've been moving and they were implementing some new stuff. So while we aren't participating in those screeners at this time, it's still a big part of what we do with our work each and every day. We had rolled out the training together with Mark, and we look forward to getting back together with our regular monthly consultations where we were already kind of focusing on the MI stuff. And it's just an easy transition to add that, as well as like we also, because we have a new license program, we got lumped into this big training with this TIP initiative, which is for transition age stuff, which it all fits together, but it was all really overwhelming and bombarding for staff at the time. But I think it's just a matter of how we continue to kind of use the terminology and meld them all together, because while they use some different language, they're all teaching and working on a lot of the same types of things. And the one thing that I'd say is a little bit different from our county, from some of the others that were involved, is while Beaver County is small, there's been initiatives in place for years around co-occurring work that we've been a part of. We had great people that were writing grants, so they were really pushing for, we're the only area that has family-based teams that can actually have an enhanced family-based program where they have a recovery coach who assists with not only recovery-based issues for the identified patient we might have, but anybody else within the family. As a result of that, we're also a part of that initiative to where every one of our staff, as part of our professional development, is kind of working towards an understanding of some COD stuff. So we're about to kick off and get started again. Beaver County offers a COD training series that's free for the county agencies. And so even some of our people who've done them before in person, now that this new batch is coming through with a new trainer and being done over Zoom in like 3-hour hunks, we're all about to continue to do that. So it's been a big push of our crisis program already. And I do think that we found, even though our staff has had some more exposure to it, we're still not as strong, obviously, in our drug and alcohol stuff as we are with our familiarity around the mental health stuff. So I think it's great for the ongoing training, continuing to kind of work on those skills, as Mark has, kind of talked about. But I also found that this training gave a little more, some practical skills for them, and some actual slides and some handouts that they were able to utilize to more tangibly quantify some of those, those basic things. I'm thinking about slides around standardized drinking units, talking about that, some of the real direct and practical applications that we can get from the screeners that we have here. So I do see us finding a way to kind of meld them in as we've wrapped up our, our research project or whatever. But I just think anything that we can do in the mental health field, which is primarily where we're working, that draws in and collaborates with drug and alcohol, is a great strength, because we're getting our kids that are through CYS, but also through juvenile probation. And I would say within our juvenile probation referrals, at a minimum, I'd say 85% where they're dealing with mental health and drug and alcohol, whether it's with the individual or at the family level. So our teams are going in and dealing with families that are, struggling with a lot of these issues all the time. So I think this is, even though we weren't participating in the surveys and using the screeners currently, I think it's something that's been a real benefit for us, and will be able to continue to be a benefit for our workers as we kind of move forward.
I have
go ahead.
Oh, can I ask a question? I'm intrigued by the one slide you said you're thinking like MI everywhere all the time, essentially. And I'm wondering, I'm imagining that you all have trained people with a wide variety of experience and skill set. So that being the case, I'm wondering if you've learned anything anecdotally or personally about sort of, what, when you think about staff, are there certain staff that take to MI more easily? Are there other staff that you have to sort of take different approaches to help them? I'm just wondering what you've learned about sort of this wide variety of people that it sounds like you've embarked on training in MI.
Yeah, so it's for me, it's really interesting because almost you're talking about it blows my mind a little bit, but I find myself using motivational interviewing to talk to people about motivational interviewing.
Yep.
Because there's this idea that, there is some old school sort of attitudes about it's either clean up or you're going to have this problem, and there's the little coercion, sometimes heavy persuasion that doesn't necessarily fit in the model of motivational interviewing, and so backing off a little bit and sort of allowing folks to be their own expert is sometimes a challenge for folks, especially folks who have sort of been through a time period when there was sort of a more hard-nosed approach to addressing substance use disorders or problems that might get you involved with juvenile justice or CYS. I think, so we have this wide variety of people who have been around for a long period of time, and we have folks that are relatively new to mental health services. And my experience has been is that the folks who have had less experience are usually the ones who will more easily adopt MI skills than the folks who've been around for a long time and not been exposed to it. And so my goal, and I'm kind of a dreamer about this, is that folks will get something, bless you, at the very beginning of their training, that they sort of start getting introduced to MI foundations, the spirit of MI, and the collaborative nature of it early, so that as we add skills, it becomes more about their attitude than it is necessarily about the nuts and bolts of it, which is really important. And Chris's program has been sort of a test market for us all along, because their county has taken on some really good initiatives, and that they want anybody who's working with kids up in Beaver right now, kids and families, to have MI training. And so they offer it from time to time for anybody providing services in Beaver County to do free 2-day MI training, and then they'll circle back with supervisors, and Chris and I went through this together to do MI coaching training also. So it's, when counties support things like that, it really helps everybody get better. But I mean, the idea of MI everywhere is it being used in supervision? How are we talking to folks when we pick up the phone? Even it's just a communication style, I think, that can be effective for any level of interaction you have with families. How we get it there, I'm not 100% sure yet, but we're really talking about it. So it's gonna come sooner or later.
Well, with MI, it's always small steps too, right?
Absolutely, right. And I have to think to myself, we really, and Chris will help me with this all the time. As a trainer or a consultant in MI, I have to watch where people are at, because I will sometimes overshoot where people are at as far as their understanding or ability, knowledge, desire to do MI. And so I have to sometimes be taken down a couple notches to sort of back off and let people absorb a little.
So I guess that's my other question for you guys. I mean, you have this large grand plan and you have a huge center. What's the next sort of small step you all are taking? What's the next thing on your?
Yeah, so as far as MI goes,
or anything related to Sbirt, I think is fine.
Yeah, so with Sbirt, really, it's going to be about community-based programs. Mainly, we have the schools and the community-based programs we'll be restarting at, and the CSBBH, and then the education service lines. But as far as MI goes, we have a committee we're meeting about how we can sort of standardize MI training as a part of our learning management system. So our director of training, Clinton Kerr, he did some MI training himself. He's in consultation with the trainer in Allegheny County to try to sort of develop something that we can do going forward. In the meantime, we're trying to fill some gaps by bringing in people like Dr. DeWahey and doing some different sort of outreach in partnership with other places to try to get MI in different places. We have a MIT trainer out east that does some training with our York program. So anywhere we can get it until we can standardize something for ourselves.
Great. I think I cut off Shannon earlier, so I'll let Shannon finish whatever her comment or question was. Sorry, Shannon.
Okay, I forget what I was going to say, but since we're on the topic of MI training, I just wanted to let you know, Mark, that everyone that applied for the Armstrong County training from Presley is in. We had enough spots, so that I think would be another step to have. I think it was 3 of you that applied to have you participate in the year-long advanced MI training.
Yeah, and our hope is in that pocket. So we serve a large part of Southwest counties, Armstrong and Indiana being a part of that is to sort of be able to become better. And just like up at Beaver, you know, when you have a county that supports, there's an initiative in a county that supports something, it really helps grow everybody around it. So I think it's another pocket we can sort of build from, which would be nice.
I think one of the most important things for us is how do you take the training that you get to staff, you work on them, you continue to build them, but then how do you indirectly affect the system, whether it's our referral system or people that we collaborate with. And we've been blessed by having really good connections with them that develop over years, because for us, sometimes there's an immediate struggle against like harm prevention or some of the other types of things, because we are getting referrals that are already part of the system or have penetrated the system. We're trying not to let them get any deeper. So sometimes you're dealing with, you know, POs that have to have a black and white, is the urine clean or not? Working with them, you know, probation officers have been a part of some of the MI initiatives, developing conversations around them and having the relationships to kind of, we're not in a flag planting business. We can't tell them what they should or shouldn't do. But as we've worked with them and they kind of learned to trust our relationships, we found that the systems that not only refer to us, but those that we refer to can get kind of indirectly influenced by kind of that spirit of MI, which I think for our organization is usually an easy fit. And if we can have it as a part of onboarding and as we move forward, because it's very closely related to the same things that are part of, you know, the re-ed stuff that we already pride ourselves on as an organization. So I think it's like kind of those next steps of giving the staff the tools so that we not only support the families that we serve, but the bigger thing that we can do is kind of, if we can start to affect, you know, our referral sources and the communities as a whole, is where you can really kind of see a lot of the benefits.
Yep. That pressure often is the reason why folks will overshoot. It's because they feel like they have pressure to make something happen, because we have sort of folks that are saying, what are you doing here? And MI has really got steam because of the Family First Act stuff that's coming out, I'm sure everybody's aware of. And so I think that's been helpful in some ways too. Folks are saying, okay, so here's this thing. And as people become more aware of what motivational interviewing is, or I think they're more comfortable with the idea of allowing things to happen in a different rate and based on what the client's able to do at the time.
Mm-hmm.
So.
Yeah, it's really interesting. County level that people are doing my trainings. There's the one in Beaver you mentioned that I wasn't familiar with. You said open for any Beaver County providers that work with, I guess, anyone with substance use or how like a possibility of interacting.
Anyone. Yeah,
That's
if you have any interaction with families in Beaver County, you can come and be. The one I went to, we had folks that were in the prison system as COs. We had folks there that were, you know, all sorts of mental health providers. Anybody can be a part of that training if you're providing services in Beaver, which is really nice. I think you don't see that too often.
And they did a similar Butler County. Actually, I think they're still in the process of doing it through the MI Institute, who's going to do the Armstrong County one, where they also opened it up to anyone in the county, and they had some juvenile justice, or actually, I don't think it was focused on adolescent. So just any sort of justice system, people that wanted to. So it's really interesting, I think, at the county level that they're starting to pick up the need for this and offering it. I'm not sure, I haven't heard of one going on in Allegheny County. And maybe because of the size of it, it's harder to do, but I think it is, yes, I feel like people that are using it are starting to influence other people to see how important it is. It just will take time, I guess, to get it to where we want it to be.
Yeah, there was some free MI training offered in Allegheny County by a couple of different people, Akey being one of them, that you know, you could request to get those done. I'm not sure where that stands right now. I can't say if it's really going on right now, but at one point we had some programs that were getting some MI through the county, so it was pretty nice too.
Yeah, I think there were some initiatives that were being worked on when we first started talking to you, because Dennis Daly was talking to us about interacting with the county, but they were already working on something and they didn't want to dilute it. So I think there's been lots of things that have come out due to the opioid epidemic. I mean, the state funded like 200 or 300 programs to do different trainings and things. So hopefully there's a lot of it seems like there's been a lot of growth from that, which is good. Although it's interesting listening to everybody speak, it sounds like there's a lot more MI training. There's a lot more thought about sort of this overlap of behavioral health and substance across the lifespan, but there's still this issue that there's only treatment for substance use in pockets of the state. I mean, that's what I hear. It's not as widespread available as it could be or should.
I know one of the obstacles that we found here is, we're dealing with sometimes some high risk kids that have high levels of usage and some really unsafe stuff. And we happen to have a kid who was expressing, her desire to go into some inpatient treatment. And there was nowhere where a kid in Beaver County that wanted to go inpatient, even voluntarily, could access us at the time, because Gateway's program had closed down. Pyramid, who previously was used through the county as a place where they could go, the only way they could access it was if they actually penetrated the system to the level of being assigned to an outside in or some of the other places that were kind of doing that. I think that was a byproduct of COVID, with numbers being so low and organizations trying to address it. But we definitely saw that with some of our higher risk clients currently. And our county, in a way, too, there's not been stuff to be able to be delivered in home for years out here with drug and alcohol, which we know are the families that we work with struggle so much with making appointments and getting it. And so when we had a provider before, he was able to do some drug and alcohol in the home and in the community, it was so much more effective. But as a byproduct of that, the county continues to kind of try to find ways to meet those needs. So a little over a year ago, they started a new program with us that was contracted for its family behavior therapy, which was this evidence-based practice where it's providing the drug and alcohol treatment for the parents of the families that we had. That program started out with 2 clinicians. It grew to 3 already, and now they're adding a 4th. And the county's actually contracting for the new calendar year of adding that for actual adolescents. So it'd be a master's level clinician who's doing it through the contracted based stuff, just as a need that the county's identified, that they've continued to expand. So it shows a little bit more about, when you're dealing with a county that's identified this area as a, an area where there was a void of how to try to think creatively and provide those services, within the county. So we've been really lucky when it comes to that here in Beaver County.
That reminds me that the state is got a group that's looking at what the needs are and what the priorities for the state should be related to adolescent substance use. And they're looking for adolescents or families of adolescents to provide information. If you all have any access to any groups of adolescents or family of adolescents that might be interested in providing feedback to the state, feel free to let Shannon know. We'll give it to the state. They're looking for family voice. Mostly because we were on the meeting and said, where's the family voice here? But so they're looking for some family voice about sort of what struggles or even what strengths as they looked for services. But my guess is going to be mostly struggles, like, what are the holes in the system and where they think what could have been useful. So if you have any families that might want to provide any voice, feel free to share it with us and we'll share it with the state.
Yeah, I'll look into that for sure. And Chris mentioned that FPT, the Family Behavioral Therapy Program. We're opening up a new program in Washington. Should be open soon, doing the same thing. So Presley Ridge and Enid itself these are 2 licensed programs that can provide substance use treatment now, which is big for us over the last 5 years that this sort of stuff has come around. So.
And are you doing inpatient treatment in Washington County as well?
Absolutely. Yep.
And do you also have the treatment for families of kids with behavioral health? Is that what you're describing, Chris?
The family behavioral therapy program really addresses it's a whole family approach. So it's a good program. Yeah.
Did I also hear there's a treatment available, substance treatment, if parents have substance that can be accessed through the kid accessing the system? Maybe I misheard.
Yeah, so like if we have kids that come through for family-based therapy here, we have the enhanced family-based option, where if that kid has usage issues or if the family identifies as ongoing needs, it activates a 3rd team member that serves as a recovery coach. And while they can't, it's again that gray area of it's versus delivering drug and alcohol treatment versus psychoeducation and providing assistance around those areas and connections and stuff like that. But that's existed for a while now. It really came out of a SCORES grant that was going on in Beaver County. I would say it feels like it was at least like 10 years ago when the first wave of it happened, where they created the recovery coach in that role, and it's kind of continued to evolve. And once the grant hit the end, the county was committed to finding a way to make it sustainable. So tying it into an enhanced rate that's paid through the MA system as well. So yeah, that's a way where even if that kid might not have the drug and alcohol usage that is our identified patient, because there's a family member or it is impacting that family dynamic, they're able to access that, that third team member to provide support in that area.
Great. Thanks for giving me more information about that. You guys just have so much going on.
There really is, and that's why anything like with the Sbirt, it's about how do we apply it. It really is applicable for everybody, but to make it fit to what they're doing is the leap. And it's not that big a leap, but it's we just have to customize and we train. So it's working out though.
Great.
So I'm thinking a good time for that 5-minute break, just so people can go to the bathroom, get something to drink. And then we could meet back at 11:25 and then just finish wrapping up the discussion. So
right.
we'll see you
Thank
back
you.
at around 11:25. Thanks.
Just a reminder to all of the attendees that if you have not registered, there is a link down in the chat window that you can click on to register. Again, if you haven't registered, please click on the link in the chat window and contact us with any questions. Shannon, it's 11:25 if you want to resume things.
Thanks, James. Okay, so I'm gonna share my screen again, so just give me a moment. Oh, and I guess before I pull up the slides, I just want to check one last time if anyone from adolescent medicine was able to join. Okay, doesn't sound like it. Okay, so I wanted to give you guys a slide with the cognito information as far as each location that's on today's call and how many staff members have activated an account. So this is just activation. A lot of these ones are completed, but these are at least that the account was created in case you needed an idea of like who you still wanted to reach out to complete cognito. Like Abby mentioned, we have the licenses through the end of the calendar year. So maybe even letting people know that, they won't be available past 2020. That might spark some people to complete them. So I'll just leave this up here for a second in case you want to write any of these down. You could also reach out to me too after the meeting if you wanted a list of all the people at your location that have activated accounts. Okay. So we wanted to just talk about some planning as far as sustainability for Sbirt at your locations. So it looks like I have something in the chat box. Let me just check it real quick to make sure it's not adolescent medicine. Oh, Mark, yes. Yeah, I could definitely give you access to those. And I plan on being at the Johnstown Day School training. So maybe we could talk this week about specifics for that. But yes, we can give them access to it.
Okay, thank you.
You're welcome. So yeah, we like to wrap up the final meetings for the collaborative talking about sustainability and some ideas that you might have for that. And I think a lot of you mentioned some of these points during your presentations, especially talking about planning for the future and your future goals. So I'm just going to look at these and have you look at them for a minute and see if there's any that we don't think we maybe touched upon yet. Okay. Yeah, so I think with some of the groups, I know Presley has a plan in place as far as having their core group of trainers, and it sounded like with Safe Harbor too. And Dr. G had to jump off the call, so we can't ask her. But I guess, so maybe for the behavioral health group at the hospital, as far as carrying on Sbirt, and I know you mentioned for like new staff coming in, do you have any ideas on a plan for maybe who would put together some material for that? Or are you going to maybe Catherine and Taylor continue on as being the champions there and maybe get some other champions or trainers to join you guys as you get more staff?
I think, Taylor, I'm speaking for you. I think we will continue to be the champions. However, in general, one of the areas as a group and a leader that I want to continue to work on is our onboarding process with new hires. So that'll be something that will be a project we'll be working on over the next year, especially as we're hoping to fill some open positions. And so we'll have a cohort of new hires in addition to Alicia Miller, who just started with us this month. So, you know, I think that'll be something that we'll be working on and will definitely be built into that project.
Yeah, and Catherine, I fully anticipated that. So no worries in speaking for me. And I very much look forward to and I think enjoy sharing these skills with any people that feel like they need refreshers, or also, as you had mentioned, we have a few open positions. So as we start to fill them, being kind of that person to introduce that to them.
That's great. I'm glad you guys want to continue on the role past this learning collaborative and continue to be champions and feel comfortable talking to people about Sbirt. So that's great. Given these points here on the screen, does anyone else, when they see any of these, think that there's something maybe that they didn't think about that they want to talk about now, or have any questions for maybe how other groups did something? I'll just give everyone a minute to kind of think about it, and then please feel free to either put it in the chat box if you have a question or just talk. Oh, and Abby, if you're on too, please feel free to add anything you'd like.
Yeah, I'm here. I mean, I think a lot of people addressed most of these areas in their presentation, which I think was great. And I think one of the hardest things, and I heard Presley talk about it to some extent, is do you have a big enough core group, and how do you maintain that group over time? Because people move, things change, and really sort of staying attuned to that year to year is really important.
Yeah, I think it's definitely something, to continue thinking about as the months, years go on. If you're starting to notice that some of your trainers are leaving or maybe taking on different roles where they couldn't, be available to do training or something like that, just thinking through how you want to fill in that gap as far as having people available to train. So these were just some other sustainability measures that I think we got from a worksheet, and we've used them with other groups. So I think this first section on measurements is a good thing to think about. Have any of you guys considered or thought about what you want to continue measuring after this learning collaborative ends? Or maybe there is something that you have been measuring as part of this that you don't find to be useful, that you think you may stop measuring. So as far as like number of screens, number of patients screening at different levels, number of interventions, number of referrals, that sort of thing. I think it's for this one, it's definitely, in my opinion, easier for the places that are documenting in an electronic medical record to continue measuring, because, as long as it's built in, you're putting the information in, and then really with most of the EMRs I know of, you can pull reports at any time through informatics. So I think that it's easier for those groups probably to measure whatever they want when they want. But for groups like, I'm thinking of you guys at the hospital who are doing it on paper for now, is that something that that you think you want to continue to collect and count every so often to see, just to make sure things are maybe staying at the same level that you were thinking they would be? Or is that something that you think maybe you'll stop doing? You'll still be doing this, the screening and the brief interventions and the referrals when needed, but not necessarily collecting the screens in a common area like you were doing for this?
I think, Shannon, I would love to continue to collect the screening, and correct me if I'm wrong, Catherine, but it is difficult just in terms of having someone to input the data into the Excel sheet. But I think for future, I'd be more so interested in interventions that are being used, not necessarily number of screeners. just to kind of ensure our overall goal of being comfortable with applying those skills, making sure first and foremost that the patients are getting what they need, the patients and families. So I feel like that's kind of my take on it. I don't know if there's anything you want to add to it, Catherine.
I agree. Taylor and I had touched base a little bit about collecting the screens after this is done and thinking about that from a data collection perspective. And Taylor's right, it's just difficult to kind of manage the input. We will be getting a new Cerner note any day now. I've gotten confirmation on that. And although it doesn't have the same streamlined process as Epic, it hopefully will centralize the documentation. So in the event that we wanted to do any kind of retrospective review or something like that, hopefully it would be more feasible. And I agree with Taylor. I think the interventions would be helpful because once again, it will also help us target where people may need support or may need training, or we may need to continue to build connections with services in the area if we're seeing, certain common themes. So I think that would probably be the most useful data.
Yeah, I think once you have that new note, it should be easier, like you said, to go back and then look at things. Since I'm not as familiar with Cerner as Epic, is it hard to get a report on something you want pulled from Cerner, or is it a relatively easy process?
Apparently it is hard. No, it is hard dependent on, there's certain things in the date and then the note that like we, for our insurance authorization, asked to be put in that kind of force clinicians to fill it out. So those things are easy to pull. And the substance use is not one of them right now. So it took quite a while for multiple reasons to get the changes to our note, which we were already making. And the next step prior to COVID was to meet with Cerner and to continue to refine that process. I think everything is slowed down, of course, right now. So we'll see, what more we can do in the future.
And do you know, I don't know if they showed you like what it will look like, but do you know if there's an area of that for documenting the intervention with the substances that are used, or is the documentation of the intervention go like in a narrative part of the note where you free text in what was discussed?
Yeah, it can be a free text, but it could be in the section where the substance use screening questions are, if I remember correctly from the last time that I saw what the note is going to look like.
I mean, the issue with Cerner is all about building it, right?
Mm-hmm.
It's harder to get access to build in Cerner. And even the builds aren't quite as simple as Epic is.
Mm-hmm.
So, yeah.
Yeah, it just reminded me of that problem we had with Epic when we were early on with putting the screens in, where I think we had the pediatricians documenting just in the note the intervention they did, so we were able to find it through a report. And then we had to get the drop down boxes added where they actually had to click on one for us in order for us to be able to see what intervention they did.
Right. I mean, I think that the building a Cerner note, they're like, that's eons ahead of where they are right now.
Yeah.
Don't you think, guys?
Yes.
Mostly. And the fact of the matter is that there's been a lot of bills that have had to happen because of COVID. So
yeah, that's true.
I'm not sure what'll be reasonable to build or not.
Yeah, but it's good that they're building something and that it sounds like it's close. I think it'll be definitely a good start.
I mean, I think what you all might need to think about is if we're doing a lot of things remote, which I know we're doing less now, but that could happen again. Should we think about other ways to get any screens from people? Because it gets really hard to do screens when you're remote, as you all experienced.
Yes.
So, and that will be that will be the new thing to deal with. Again.
Yeah, that's so true. It is way harder. So because you can't hand someone a paper or a tablet when you're meeting with them. over tele. So yeah.
Right, and it takes time to deal with the getting people connected and all of the IT peeps, so screens get pushed aside, understandably.
So for the ownership section on this, I think that, and anyone, if you have other feelings about it, correct me if I'm wrong, but it sounds like this group, this core group that's on the phone for all of these different organizations, that you would be taking ownership of this moving forward, and being the ones that are engaged in improvement and sustaining it over time.
That's what it sounds like to me.
Yeah. And then for communication and training, how will we communicate about change? Who will be the messengers? Yeah, so I mean, I guess just thinking about, and you don't have to answer it now or have a definite way you want to do this today or now, but just thinking about for the future, if there were to be some change to, for example, S2BI is supposed to have a new version coming out hopefully soon. It's been a long time for them saying it's going to be coming out, but there's supposed to be a vaping question added in there. So, say it comes out next month, just for example, how would you communicate that change to the staff members that are doing the screens? Do you have a certain person that's going to do that, or a team, or a meeting? However you want to do that, maybe think it through for when things like that happen. And then how will we support individuals? Sorry, my screen's blocked here. I can't read that word. Oh. How do we support them doing the new right way? I know a lot of you guys talked about fidelity to the model. And I think that, really keeping people trained on how to train has been, a big part of this. What type of training will we use? And I think also with that, even though a lot of us were doing in-person trainings, even for this learning collaborative, we were pretty much all in person except for the monthly check-ins. I think we're all adapting to virtual now. And I think, at least for Sbirt, the biggest challenge for me has been with the virtual trainings is the role plays. I feel like I still haven't found a way to do role plays as well, I guess, with as much impact as they would be in person. So maybe even thinking that through, is there a way you want to train the role plays, whether it be virtually, or if you have the opportunity to do it in person, that's ideal. Has anyone done role plays either for Sbirt or for like a different topic virtually and had any luck with them? Yeah, I think it's hard. I think if you are able to do the little breakout rooms like Mark had mentioned with Zoom, that's helpful. I know, Abby, when we did our 2-day training last week, we just weren't really able to do them. So yeah, I think it's just something that all of us are going to have to hopefully get creative with and maybe better at over time.
One of our groups last week did something that I thought was really effective, that I think we're going to try, is that, well, we broke people up into groups and we had them talk amongst themselves about a couple things and then teach back, because that's part of the train the trainer. But one of our groups actually practiced a role play and then did it for everyone.
Oh yeah, they did. You're right.
That was effective, and that means they practiced too. So I think we may try to experiment with that. I think the key thing is we're still trying to work through creating breakout groups and creating sort of a breakout group that communicates with each other, so that they can do all these things. So I think we got closer with a very small breakout group of, it was only 3 or 4 people, and they had time multiple times, and they had something that had to do at the end, like a product. So that helped, I think.
Yeah.
But we're
I forgot about their role play. It was really good. And yeah, I think it was because, I think had we just asked for maybe volunteers, it maybe wouldn't have gone so great. But I think the fact that we assigned things they had to do probably helped. So maybe even for if you're going to do role plays, assign certain scenarios to certain people so that they, know what they need to be doing, and then they can maybe practice in a smaller group and then bring them back to the full group to go through the role play. I know just like in some other trainings I've done where I've had like little questions or examples or scenarios, and I've asked like for volunteers to answer, I usually just have to answer it myself because no one will say anything, which is, not the best. So maybe assigning things to people so that they know what's expected of them. And it's not so much just everyone's waiting for someone else to talk type of situation. Okay, hardwiring the change. How will you make it hard to do the wrong thing and easy to do the right thing? How can we reduce reliance on human memory? Well, I think for that, a lot of you having this built into your electronic medical records or having paper forms so that you are going up based off of the standardized screening tool and not just going off of, memory for the questions, is really important. And we talked about documentation resources. Does anyone else have anything that they do or maybe have been kind of telling their organization about to try to get them to remember to do Sbirt, or does it seem like it's to the point where it's just kind of become a standard practice for all of you?
For us, I think that one of the things we have to figure out how to do is we typically do quality record review. So we do internal auditing of all of our stuff. And this becomes one of the things that we should probably put on those forms as we're starting to score them. So it's, our internal auditing process has to be improved. That's typically how we catch these things. With our electronic health records, you can run a report that sees, if you have compliance. So we can, do these run reports based on whether or not we see one of these appear within the first 30 days, and then send a report back to folks. But and as we're getting better at running adherence reports, we can start doing that for these groups. But really, it comes down to that auditing process. That's the way we're going to have to make it work.
Good. It's like if you saw maybe one certain department or something where it wasn't happening, maybe doing a refresher course, or if it's more of like individual people here and there that are forgetting, then maybe it can be addressed in supervision or something like that.
Yeah, that's one big benefit of electronic health record is finding access to that information very quickly without having to wade through a bunch of files. Is to be able to pick those areas where we're having problems out pretty quickly.
Good. It sounded like someone else may have been trying to say something, or it might have been background noise, but was there someone else trying to talk?
I think I was agreeing loudly, sorry, about the electronic medical record statement.
Yeah. Okay, and then assessment of workload. Are our changes increasing the overall workload to the system? If so, how can we decrease the workload? If not, how will we communicate about what is changing and not changing? So I think, Presley, you guys hit upon this too, because you said that there is a lot of assessments in that first 30 days, a lot of paperwork, and that you're trying to, avoid adding extra unnecessary paperwork. So it sounds like you guys have been thinking about that and being thoughtful with deciding what to put in. Does anyone, I guess, that has any of these other groups, do you think that adding Sbirt has been something that has added a whole lot extra to people's workloads, or does it seem to be something that's manageable? I feel like it's one of those things that people get really worried that it's going to take a ton of their time, but then when they actually start it, then they realize that, some days, will take some time depending on what screening results are and how much time you need to spend talking about it. But for the most part, I think they're pleasantly surprised by how quickly they can do some of these things. Has anyone?
Say the big thing I've noticed across services is that it doesn't take that long to do Sbirt, but it's hardwiring it so that it's easy to do it, so that stuff's where it needs to be, so it's clear when it needs to happen. Most providers don't have trouble with the idea of doing Sbirt. If a kid really is using substances, they want to know. They want to help if they can. So, I think the biggest issue is making sure that you make it easy for them to do the screen piece, and then the training so they can be doing Sbirt well, which is sort of the next piece that Catherine and Taylor were talking about. So, making sure they're moving to intervention.
I just saw something come in the chat, so I was just going to look. I think it was just a reminder to register. If you did not register for this and you got the link from me this morning, then that means you need to register. So this link on the side here in the Zoom group chat, that's what you want to use to go on and do that, so that Doreen and Nancy can count you as being here and get you the appropriate CEUs for attending today. So anything else that you guys, or Abby, anything that you are thinking about and maybe have some questions about moving forward, or any concerns about anything?
I don't have a concern, but I wanted to thank you both. Thank the whole collaborative. I mean, this has been a really rewarding experience for us. It's funny that this was a year. It seems like it was didn't go that. It was an odd year, but yeah, it went fast.
Yeah.
In the future, and I know that I probably know what the answer to this is, if we're running into problems where we need consultation or help as far as updates or materials, who can reach out.
Oh, of course. Yeah. Yeah, please reach out to me if anything's coming up that you need help with. Just email or call. I think you have my phone number too, or call. Be more than happy to help you work through anything that's going on. And that goes for all the groups. And and thank you to all the groups for so much hard work that you've put in. I know some of you guys have been in, depending on when you started, have been in this group longer than a year. And have been, attending all these monthly calls, and I know it's been, it takes a good bit of time to work on these things. So I want to thank all of you for all of your hard work. And I think especially seeing the presentations today, I could see how much work was put in and how impressive it is that you guys have taken things. Some places weren't even screening at all. And from screening to all of this implementation and expanding into different areas of your organizations, I think it's really amazing.
Yeah, I want to thank everyone for participating too. I mean, we've done this with probably over 30 places now, maybe over 50. I've encountered recently. And I would say everybody's put a lot of work, everyone's made progress. No one ever feels like they've made enough progress, which I guess I just want to remind people, sort of the conversation we were having about MI, like it's all about just hanging in there and continuing to make some progress. I think everybody in this group did a great job continuing to hang in there despite a wide variety of potential issues, not the least of which was COVID. So thanks everyone for being here. Thanks for participating. I learned something in every single one of these learning collaboratives, and it's been great to see sort of how everybody can just make Sbirt their own, and to just see how far we've come. When we first started Smart Choices in like 2013, there was a lot of reticence to talk about substance, even in behavioral health places, let alone primary care. And it's changed so much. It's not because of us. We just happen to be around at the right time, and it's been fun to try to facilitate that so that we can really do a better job in getting kids in the right place on the best course for them. So thanks everyone for all you do. Pat yourself on the back for the hard work. And I think we're letting you out, about 20 minutes earlier maybe than we said we would. So it's sunny here. So if it's sunny where you are, go enjoy the sun if you can. Shannon or Doreen or anybody else have last sort of comments they want to make or need to make to?
No, this is Doreen. Just if people who haven't registered, once again, thank you for mentioning it again, Shannon. If you haven't, please register so we have your information. And the link I just put on, that is correct. been a
Thank
little
you.
bit of a funny morning this morning. It's like Monday, only Monday. Okay, so anyway, please use that link and let us know. Well, Nancy, once you put that information in, which please do today, Nancy will be sending out an email with a link so you can get the ball rolling on your continuing education credits and continuing medical education credits. So thank you for doing that.
Awesome. And so obviously, like, this is formally over, but if people want to give us future updates on sort of where they are with Sbirt, where they are with MI, progress you've made, we'd love to hear it. So feel free to share. And I think we're done then. So have a good day, everybody.
Thank you, everyone.
Bye-bye.
Bye.
Thank you.
Thank you.
Thank you.